Welcome to Mastering Differentials, an approach to clinical medicine history taking. I am Dr. Fahad Khalik, and in this video, we're going to discuss about different presenting complaints and symptoms and a diagnostic approach to history taking. So sit tight and follow along with me through this whole sketch in which we're going to start from the constitutional symptoms. So starting with the constitutional symptoms, we have a mnemonic and that is SWAN beside CPR. Now, what does that stand for? Sleep, weight, it could be weight loss, it could be weight gain, A for appetite, and N for night sweats. Then B beside, B stands for bone pain, and CPR. C stands for chills, P stands for pyrexia, and R stands for rigors. So let's draw a scene where the girl is giving CPR to the boy and the swan are beside it. Now we start our first constitutional symptom, that is sleep. And we're going to represent it by an old man who is just sleeping on the bench. So a patient can present to you with the loss of sleep, and this is known as insomnia. And in that case, you're going to ask about the normal sleep pattern of the patient, followed by change in the sleep. Then you're going to ask about the timing of insomnia. If it is hard to go to sleep or is it hard to wake up in the morning. Then we're going to ask about the associated symptoms with the loss of sleep, and these could be anxiety or depression. Now we're going to represent anxiety with this anxious pop-up balloon and depression with this semicolon pop-up balloon. What else are you going to ask about the patient? With the loss of sleep, you're going to ask about any cardiac disease or any respiratory disease or any other cause of pain, which are represented by the hospital with the logos of heart, lungs, and shock. Now I think it's time to move on to the second constitutional symptom, which is weight loss. And by weight loss, I mean significant weight loss, which is just drop in more than 5% of the total body weight in 3 to 6 months. We're going to represent this weight loss with the weight having an arrow that is going downward. Now for the weight loss, we have common causes, for example, infections like TB, endocrine diseases, for example, diabetes, hypothyroidism, Addison's disease. We have liver diseases, for example, hepatitis, DCLD. We can have chronic renal failure, malignant diseases, for example, lymphomas, leukemias, carcinomas of stomach, colon, liver, pancreas. We can have different blood diseases, for example, anemias. We get the weight loss. And in the psychological symptoms, for example, anorexia nervosa, bulimia nervosa, we get the weight loss. And we can have miscellaneous causes, for example, malabsorption syndromes or the infestation by the worms. Now, in a patient with the weight loss, you're going to ask about the collar size of the shirt. Has it decreased significantly or not? Then you're also going to ask about the onset. Is it recent weight loss or is it chronic? Now, the recent one is more significant. And finally, you're going to ask about the normal dietary habit of the patient to separate out the physiological weight loss from the pathological one. Now, let's talk about some associated symptoms which you're going to ask the patient. First of all comes the tuberculosis, which is represented by this cavitary cacti. In that patient, you're going to ask about cough, sputum, hemoptysis, fever that worsens on evening and night sweats. And now it's time to ask for the cirrhosis of the liver, which is represented by this cirrhotic tree. In the patient of DCLD, you also get to see weight loss. And in that patient, you're going to ask about jaundice or abdominal distension. Next, we can have weight loss in a patient with chronic renal failure, and you're going to ask about nausea, vomiting, and metallic taste of the mouth. And this chronic renal failure is represented by these hanging injured kidneys with the tree. Next up, worms infestation. Now you can really ask the patient if they can see worms in their stools. And here we're going to represent this worm infestation by these worms which are going above the tree. What are they going after? Well, good question. They're just going after a jar of sweets and candies, maybe? Yes, you're right. They're just going after a jar of candies, which is going to represent the diabetes. So in a patient with diabetes and weight loss, you're going to ask about symptoms, for example, polyuria, polydipsia, or polyphagia. You can also ask this patient about the complications of diabetes, for example, any past history of cerebral vascular accident, MI, stroke, or peripheral arterial disease, which are actually the macrovascular complications of diabetes. You can also ask about the microvascular complications, for example, retinopathy. Ask them if they appreciate blurring of the vision, flashes, floater, which indicates cataract. Also ask them about the symptoms of kidneys, for example, froth in urine, which is going to tell you about proteinuria, or simply you can ask about the frequency of micturition. And finally, the third microvascular complication, you can ask about the tingling, numbness, burning feet, which are just telling you about the neuropathy. Next, we can have weight loss that is associated with the hyperthyroidism, and that is represented by the thyroid purple bow on the girl's neck. Now, in a patient with the hyperthyroidism, you're going to ask about the intolerance to heat, tremors, excessive sweating, or you can just see a thyroid swelling in the neck. Moving on to the next associated symptom of weight loss, we get anxiety and depression. Next up, another strong association of weight loss is with leukemia and lymphoma. So you're really going to ask the patient about lymph node enlargement. Do they appreciate formation of these subcutaneous nodules in the neck, axillary, or groin region? And if they say yes, you better keep tuberculous lymphadenitis, lymphoma, and lymphocytic anemia in the back of your mind. Just like leukemia and lymphoma, we can also get weight loss in carcinoma. So we're going to represent this carcinoma with a cancer crab symbol. Now, if a patient has weight loss with a carcinoma of stomach, they're going to come with a dyspepsia, vomiting, with or without hematemesis. And for example, if they get colorectal carcinoma, they're going to come with a recent constipation, tenesmus, and blood in stools. Now, this cancerous condition is really strongly associated with the weight loss. Well, what more can we expect from a patient with a weight loss? Well, glad you asked. We can always expect malabsorption syndrome, which is represented by this bulky, frothy, greasy stool. Ah, she's giving CPR beside a poop? Ew. So let's go somewhere else and find more constitutional symptoms, and look what we got. The appetite store. And this appetite store has two parts, one with the increased appetite and the other with the decreased appetite. First, we'll talk about the conditions in which appetite is significantly increased, and first of all is the thyroid. In hyperthyroidism, the appetite is significantly increased, which is represented by this purplish thyroid bow on the girl's neck. Now let's see what else she has to offer. She is selling some jar of candies. Well, she's selling actually diabetes. And what else? She's selling poop. A yellow, greasy, bulky, frothy poop. Well, I know what is it. It's just malabsorption syndrome. Hey, ma'am, look out. The worms are coming for your sweet candies. Ah, help, help. This is worm infestation. So the appetite is technically increased in hyperthyroidism, diabetes, worm infestation, and malabsorption syndrome. That's enough for increased appetite. Now let's talk about the conditions in which appetite is significantly decreased, and we got here a cancer crab. So in these cancerous conditions, like I told earlier, the appetite is significantly decreased. What else do you have to offer? Ah, eggs. Eggs? But these are suspiciously looking like lymph nodes. So in leukemias and lymphomas, the appetite is significantly decreased, and the patient is going to come to you with the presenting complaints of lymphadenopathy. And now we have a beautiful decoration piece between these two markets, which is suspiciously looking like a cirrhotic tree. Oh yes, it's DCLD. So in cirrhosis and decompensated chronic liver disease, you get reduced appetite. And whoa, wait. This boy has one more thing to offer, and that is an injured hanging kidney, which is just telling you about renal failure. Oh man, you're just selling a lot of stuff. Doesn't this just give you anxiety or depression? Oh yes, of course you do get. So in anxiety and depression, you also get reduced appetite. We have a beautiful cavity cactus in the front of the shop, which is just telling you about the tuberculosis. Next up, we get the Addison's disease, and this is represented by Addison's logo. So Addison's. So in the Addison's disease, you get reduced appetite, and I think now it's enough for the appetite store. We'll check up later. Now it's time to move around and find the other constitutional symptoms, and look what we found. We found a skull with the bones, which is going to represent bone pains. Now, this bone pain is strongly associated with the cancer if there are big bones, and it's also associated with lymphadenopathy. And this lymphadenopathy is represented by this necklace, just looking like lymph nodes. Anyway, so bone pain is also because of trauma. So make sure you take a proper history. And this trauma is represented by this axe, which is just stuck into the head of the skull. And you know what's worse? With this axe is attached some weight. It's just telling you about the weight loss. So in the bone pains, you really need to keep cancer, lymphadenopathy, trauma, and weight loss under strong differential. Okay, I think it's enough for the bone pain. Now let's move to the night sweats. The night sweats is caused by TB, B symptoms, for example, in Hodgkin lymphoma, leukemia, and brucellosis. So for the night sweats, we start by drawing the brucella cow. Now this cow is really telling you about the brucellosis. Now this cow has a beautiful strap in the neck, and on that strap is written B. Now B stands for, the brucella cow, and also B stands for the B symptoms of Hodgkin lymphoma, leukemia, and so and so. Next, in the chemistry cactus, tuberculosis, we can also get these night sweats. Okay, so until now, we have covered a lot of constitutional symptoms, for example, sleep, weight loss, appetite, bone pains, night sweats. And now let's move on to rigors and chills. Now, do you see this couple of swans? Well, they're very toxic in their relationship, and they're also floating in a toxic water. Now, this toxic water is represented by this toxin sign, and this toxin sign is also the sign for septicemia. So these swans are basically floating in septicemic water. What? Also, this pond is very dirty. You can see an apple pie at the edge. So in pyogenic infection and septicemia, you get rigors and chills. So to add fuel to the fire, or you can say just add more germs to the already dirty water, here are the mosquitoes bringing for you the malaria. So basically you get rigors and chills in malaria, septicemia, and pyogenic infection. Now let's move to the final symptom, and that is fever or pyrexia. Now the fever is something that is about 99 degree Fahrenheit or 37.2 degree Celsius. Now to talk in general, the fever has a lot of causes. For example, protozoal infection, malaria, you get fever. In the bacterial infection, you get fever. For example, typhoid, TB, pneumonia, empyema, lung abscess. In viral infection, you get fever. Influenza, measles, mumps, autoimmune diseases, you get fever. For example, rheumatic fever, SLE, or dermatomyositis. And some malignant diseases, you get fever. For example, lymphoma, leukemia. And you get iatrogenic fever, that is drug induced, and if there is no significant cause, you can just call it habitual hyperthermia. So to summarize, there are just a lot of causes for the fever: protozoal, bacterial, viral, autoimmune causes, malignant diseases, or it could be just iatrogenic fever. Now, when a patient comes with the fever, you have to ask about the duration of the fever. Is it just short duration or long duration? If it's short, it's mostly like because of just minor viral infection, pharyngitis, tonsillitis, or if it's just long, it could be chronic malaria, enteric fever, TB, brucellosis, autoimmune diseases, or just malignant diseases. Next up, you're going to ask about the onset. If it's sudden, it could be malaria, it could be pyogenic infection. If it's gradual, it could be enteric fever, TB, brucellosis, connective tissue disorders, or if it's with rigors, you get the malaria, septicemia, and pyogenic infection from our swan's dirty pond. Next, you're going to ask about the severity. If it's low grade, that's because of tuberculosis, brucellosis, connective tissue disorders, or some malignant diseases. If it's high grade, that could be because of any other disease. For example, it is in meningitis, pneumonia, pyogenic infection. And one more thing, don't forget to ask about the character of fever. If it's intermittent, if it's remittent, if it's continued, or just palabstine. And this palabstine is found in brucellosis and Hodgkin's lymphoma. Then you're going to ask about the diurnal variation of the fever. If it significantly rises in the evening, that's because of tuberculosis, brucellosis, and lymphomas. Next up, don't forget about the effervescence of fever. Now, if that subsides suddenly, that's because of malaria or pyelonephritis or empyema. And if that subsides gradually, that's because of enteric fever, tuberculosis, or just brucellosis. Next, you're going to ask about the relieving factors in which we can get antipyretic drugs. Also keep in mind the naproxen test for the neoplastic fever. Phew, there's a lot of detail about the fever. But wait, I think you want more. So let's talk about the associated symptoms with the fever. Now, to represent this fever, we're going to draw this ghost rider. Starting from top to bottom, we get the headache, which is represented by this headache cap. Now, if the patient has fever with a headache, that could be because of meningitis, encephalitis, or if it's the worst headache of their life, that's because of subarachnoid hemorrhage. Next, we can have sore throat that is represented by this red handkerchief in the neck. Now, if there's a patient with a sore throat and fever, that could be because of pharyngitis or tonsillitis. There's one more thing to add to the neck. These are electric shock signs, which are going to represent the neck stiffness. So, if there's a patient with fever and neck stiffness, that could be because of meningitis, encephalitis, or subarachnoid hemorrhage. What else are you going to ask about in a patient with fever? Well, you can ask for pain in chest, pain in abdomen, or pain in lumbar region. Now, if there's combination of fever and chest pain, that could be because of lobar pneumonia or simply pneumonia. If there's copious foul-smelling sputum, that could be because of lung abscess or bronchiectasis. Or if there's fever with hemoptysis and chest pain, that could be because of tuberculosis, bronchiectasis, or just pulmonary infarction. Talking about this pain, a pain can have different characters, and we're going to talk about that in the cardiology section coming up later. Right now, just remember if there's pleuritic chest pain, fever, cough, or hemoptysis, the causes are just respiratory. Now, that was pain in chest with fever. Well, can we also get pain in abdomen with fever? Oh, yes, of course we can. Now, if there's pain in abdomen and jaundice and fever, that's because of viral hepatitis or hemolytic anemia, or just jaundice and fever, that is because of cholangitis. So that's really the problem of liver and hepatobiliary tree, which you need to keep under strong differential. So just like pain in chest and pain in abdomen, there could be pain in lumbar region, and if associated with dysuria, that is because of pyelonephritis. So in pyelonephritis, you really get pain in lumbar region, dysuria along with fever. Next up, we can get combination of fever and joint pains, which is just arthritis, swelling, and redness. Now that is seen in rheumatic fever, rheumatoid arthritis, SLE, and septic arthritis. So you really need to keep these diseases under your differential while dealing with fever and joint pains. Now there's another combination of fever, and that is fever with flamy urine known as dysuria. Just like this flamy iron chain dripping and melting in front of our ghost rider. Now if you get fever and dysuria, which is just flamy burning urine, you get pyelonephritis. Right now, we have covered a lot of pains. For example, pain in head, which is just headache, pain in neck, which is neck stiffness, pain in throat, which is sore throat, pain in chest, pain in abdomen, pain in lumbar, pain in joints, and painful urination. So these are the really strong associations with the fever you really need to keep in your mind while taking history. Now that's a very long list of associated features. I think you want more. How about we talk about diarrhea? Now, as you can see, the ghost rider has dripping mud from his butt. Well, anyway, that is just telling us the diarrhea. Just remember that. Now, the diarrhea can really come in a lot of flavors. For example, watery stools, bloody stools. If it's watery, that's because of viral gastroenteritis. If it's bloody, that could be dysentery, ulcerative colitis, or Crohn's disease. Now this doesn't look like a Ghost Rider anymore, and to add more to it, we just give him a bracelet in the thighs. And that bracelet is suspiciously looking like lymphadenopathy. Now if there's combination of fever and palpable lymph nodes in cervical region, axillary or groin region, that could be because of tuberculous lymphadenitis or Hodgkin's, non-Hodgkin's lymphoma, leukemias, acute leukemias, infectious mononucleosis, and so and so. So you're really going to ask the patient with the fever if they can feel some nodules underneath their skin. Now until now we have really loaded things. Now to take some out, we're just giving him weight loss. That weight fits beautifully with its burning metallic chain. Just before you see a patient with fever and ask about weight loss, keep in mind not every weight loss is significant weight loss. So make sure you're going after the significant weight loss only. Next up, if you see any patient with a fever, ask him about the rash. Now, if there's fever and rash, that is because of measles, chickenpox, rheumatic fever, or it could be drug reaction, or SLE, or infectious mononucleosis. So it's very important. Just ask this. So to remind you of rash, I have drawn these pinkish nodules all over his body. And it's done. He's no longer looking like a ghost rider to me. He's just looking like a psychopath who has just escaped from a mental hospital. So the final take-home message with the patient with a fever, if you don't find any fever, that is because of psychogenic fever. And just to remind you that fever is also associated with jaundice, just like we discussed in viral hepatitis or hemolytic anemia, we're going to give this clown a yellow tinge. To summarize this all, if you see a patient with fever, you're going to ask about the following: headache, neck stiffness, sore throat, cough, chest pain, pain in abdomen, pain in lumbar region, pain in joints, painful urination, diarrhea, lymphadenopathy, rash, jaundice, weight loss, or just it's psychogenic. Phew, we are done with the constitutional symptoms. And just as a refresher, we can ask the patient about sleep, weight loss, appetite, bone pains, night sweats, rigors, chills, and pyrexia, which is just fever. Moving on to the next, we have a new scene, and that is known as peck and pea pods with Roma and Jones. Now, what does that mean? Peck. P stands for pain in chest, E for edema, and C for claudication. Then we get P pods, P for palpitation, and then pods. P stands for P and D, O for orthopnea, and D for dyspnea, which is just exertional dyspnea. And we have pods, S stands for syncope. And besides that, also we have Roma and Jones. Roma is here to remind you of rheumatic fever, and Jones is the famous Jones criteria for that fever. So now let's really dive into the scene to see this show. We have a bodybuilder, and that is going to represent pain in chest because he's showing his pec muscles. If we talk about the chest pain, we can have a lot of causes. For example, angina, MI, psychogenic, non-specific, which is just called musculoskeletal pain. It could be pneumonia, pneumothorax, pericarditis, or PE. All you have to do is ask about the character. If it's crushing, pressure-like heaviness, that's because of angina or MI. If it's dull and pleuratic, that's because of pericarditis. If it's pricking, that's psychogenic. If it's burning, that's because of GERD. So it really depends upon the character of the pain. Next, you're going to ask about the radiation. If it's radiate to the neck, left shoulder, jaw, that's because of angina or MI. Or then you'll ask about the time. If it's less than 30 minutes, that's because of angina. If it's more than 30 minutes, that's MI. If it's just for a few seconds, that's because of cardiorosis. And if it's continuous for hours to days, that's because of pleurisy, pericarditis, or just musculoskeletal chest pain. What about aggravating factors? Well, you can ask if it gets worse with cough and respiration, that's because of pericarditis or pleurisy or just musculoskeletal pain. If it's just getting worse with the exertion, that's because of angina or MI. If there's discomfort on lying down, that is because of GERD or COPD or pancreatitis. And if there's pressure, that is because of musculoskeletal chest pain, pleurisy, or pericarditis. On a short note, just ask about onset, duration, intensity, progression, associated factors, relieving factors, aggravating factors, character, and radiation. Then you're going to ask about the relieving factors. The unstable angina and MI are not relieved with the rest. However, stable angina is just relieved with the rest. Oh my god, that's a lot of detail on chest pain. Now, what are the associated symptoms with the chest pain? You're going to ask in the patient. First things first, let's talk about fever. If there's a patient with a fever and chest pain, that's because of pneumonia, pericarditis, or just myocardial infarction. Wait a minute. This bodybuilder is with handcuffs? Really? Oh, that's there to remind you of cough. Now, that cough could be dry, could be blood stained, or just rusty or yellowish. Now, if there's dry cough with chest pain, that's because of pleurisy. If there's frothy sputum, that's because of left ventricular failure. If it's blood-stained cough, well, it has a lot of causes. For example, acute bronchitis, chronic bronchitis, lung carcinoma, ABPA, pulmonary tuberculosis. We get the pulmonary embolism, pulmonary AV malformation, bleeding disorders. We get the mitral stenosis. We get the small vessel vasculitis, for example, the good pasture syndrome. And there are a lot of causes for hemoptysis, but that's really not the case. We're just looking for blood-stained sputum with fever. So in this case, the cause is going to be pulmonary infarction. That's because of pulmonary embolism. Now, one more thing, if the color of sputum is yellowish or just rusty with a fever, that's because of pneumonia. Next, what else are you going to ask in a patient with a chest pain? Of course, you're going to ask about cold sweating. And this cold sweating is seen in MI And if it's with fever, it's seen in pneumonia. Now we're going to draw this policeman, and I understand why this bodybuilder is locked with handcuffs. It looks like the officer is just in a hurry, so this is going to represent the breathlessness, and he is also very anxious about his duty. So we draw anxiety symbol. It's chest pain with anxiety, that is because of cardiac neurosis. And if there's breathless with chest pain, that's really a non-specific symptom and could be associated with pneumonia, MI, pulmonary embolism, pneumothorax, or even cardiac neurosis. So just as a recap, in a patient with chest pain, you're going to ask about fever, cough, cold sweating, anxiety, and breathlessness. On to the next, we got this edema. And we're going to represent this edema with a big water tower in the back of the show. This big water tank is our symbol for edema. Now to talk about edema or generalized swelling, we have a lot of causes. It could be transitive, it could be exudative. Now if we talk about simply transitive causes, we get the liver, heart, and kidneys. For example, cirrhosis, we get the congestive heart failure or the nephrotic syndrome. If we talk about the exudative causes, we have myxedema or angioedema. And if you see a patient with edema, you're going to ask about the duration and onset. If it's a short history, that's because of angioedema. If it's long history and gradual, that's because of heart, kidney, liver, or just thyroid, which is myxedema. Now, if you see a patient with a generalized swelling, you're going to ask about the pattern. If it involves lower eyelids first and the patient complains of periorbital puffiness when he wakes up early in the morning, that's because of nephrotic syndrome. Next, if the generalized swelling starts from abdomen and then extends to the feet, that is because of cirrhosis. And if it starts from the feet and moves to the abdomen, that's because of congestive cardiac failure. If it's generalized, that is because of myxedema. If it involves eyelids, there's puffiness in the face, urticaria, itching, and there's formation of wheals, that is because of angioedema. Then you're going to ask about effect of posture and pressure. If it's increased by walking or standing or just hanging their legs down, that is just pitting edema. And the causes are heart, liver, or kidneys. And if there's no effect, that is because of non-pitting edema and could be because of myxedema or angioedema. Now that's a long lecture on edema. Why not we just dive into the lecture and see the associated symptoms, please? Okay, so first of all, we get here dog, an itching dog who is just itching so hard. And just beside that dog is a wheel, a cart wheel. So if edema or generalized swelling is related with itch and formation of wheels, and there's involvement of eyelids and there's puffiness of face, that's because of angioedema, my friends. Next up, we draw a little kid that was invited to the pet show as a chief guest. Joking. Anyway, we have this kid, and this kid is having urination along with discomfort in lumbar region. So if there's oliguria and discomfort in the lumbar region along with generalized swelling, that's because of nephrotic syndrome. Next, we have another bodybuilder of the pack show, and he's just lying flat on the stage, and that's because of orthopnea. Also, you'll notice that he's having features of breathlessness. So if there's breathlessness on exertion, orthopnea, PND, dyspnea, and the pain in right hypochondrium region, that is because of congestive cardiac failure. Now, sometimes along with these features, you get pain in the chest. So we have given this bodybuilder elastic bandage around his chest. And this elastic bandage is going to remind you of the chest pain. Next, we see what we have here. Oh, there's a beautiful thyroid bow. I think this belongs to the urinating kid. Hey kid, when you're done peeing, just remember to take it back. Anyway, this thyroid bow is here to remind you of the hypothyroidism. And the patient is going to come with the generalized swelling, lethargy, sleepiness, intolerance to cold, hoarseness of voice, constipation, curly hairs, dizziness, and choking by their own tongue. Now, these are the symptoms of hypothyroidism, and you should keep it under your differential. Next up, we draw a cirrhotic tree that is going to tell you about the cirrhosis of liver that can also be a cause of generalized swelling or just edema. And along with this cirrhotic tree comes wheat crops. And these wheat crops are going to tell you about the celiac disease. So in celiac disease and other malabsorption syndrome, you lose proteins and you get edema, and this is pitting edema. And next up, just before we finish edema, you have to ask about aggravating factors. Does this swelling increase with the use of salt or drugs? If it increases with salt, that's because of CCF, cirrhosis, or nephrotic syndrome. Or if it increases with drugs, that's because of allergic angioedema. And not only this, you're also going to ask about the relieving factors. For example, diuretics, thyroxines, antihistamines, or steroids. And then you're finally going to ask about the progression. If it's getting worse, that's because of heart, kidney, liver, or just thyroid. Or if there are attacks, that's because of angioedema. Now let's move on to the claudication, also known as intermittent claudication, and for that we're going to draw another wrestler who is just having cramps or pain in his legs, just like claudication. Now this claudication really depends upon the condition of vessels, and you're going to ask a lot of things from the patient. For example, smoking, diabetes, hypertension, lipid levels, or lifestyles. And normally the patient is going to present with a pain in the thigh or calf or hip. Now in this whole scenario, you're going to ask some questions. For example, does it get worse with walking? Then you're going to ask about the claudication distance. See if the patient tells you they stop walking because of pain. Ask them how much time do they need to work again. Ask them if resting ameliorates their condition. Then just ask them how much they can walk again after taking rest. And finally, you're going to ask about their ability to walk. Now, there is a very important differential of this intermittent claudication, and that is neurogenic pain. Now, there are symptoms of lumbar spinal stenosis on one or both legs, and they're worsened by walking or standing, but they are relieved by bending waist and changing position. So, long story short, you're going to differentiate neurogenic pain from intermittent claudication, and claudication is strongly associated with cigarette smoking, diabetes, hypertension, bad lipid profile, and of course, bad lifestyle. Next up, we draw this cute little kid who is just palpating these pea pods. So this palpating kid is just going to represent about the palpitations. Now what is palpitation? It is just the awareness of cardiac contraction. If we talk about the causes, it could be sinus tachy, extrasystole, paroxysmal atrial tachy, or just AFib or flutter. So while taking history, you must ask about the duration and frequency. If it's long-standing, on daily basis, that's because of sinus tachy. Then ask your patient what exactly is wrong with you. Yes, you have to ask about the exact complaint. Say missed beats, that's because of extrasystole. If they say heavy humping beats, that's because of sinus tachy. If they say racing heart, that's because of paroxysmal atrial tachy. If they say fluttering beats, that's because of AFib or A-flutter. Now it's time to turn into an inspector and find out the underlying aggravating cause. Ask them about anxiety, exercise, fever, smoking, strong tea, coffee, or anything that stimulates it. So we draw anxiety on this palpitating kid. Looks like this kid is anxious to touch these pea pods. Hey, you're just peeing around. I just complimented you and you're just peeing? Bad kid. Now for palpitation, if you get polyuria after palpitation, that is because of paroxysmal atrial tachycardia. That's a lot of urine. Bad kid. Then we draw another kid who just looks like his own brother, or maybe he's just a brother from another mother. Anyway, you see those baggy blue pants? That's because of pedal edema. Now, if you see a patient with swelling of feet, breathlessness, orthopnea, dyspnea, PND, that's because of congestive cardiac failure. And along with these blue baggy pants, he's wearing just what? Bro, these are for girls, not for you. Anyway, serious. Anyway, as far as my analytical skills are telling, this boy has a great spice and sense for the fashion. He's just wearing baggy blue pants along with a white bra. And this white bra is going to tell you about the central chest pain on exertion. That is because of ischemic heart disease. Moving on to the next symptom, we have syncope. So for it, we draw this syncope windmill. And why is that for? Don't ask me. I just don't know. All I know is this windmill is going to represent syncope. Thank you for your concerns. Now, what is syncope? It's just called fainting or sudden brief loss of consciousness. Now, if the patient is young, you can think about vasovagal or hysterical. Or if the patient is old, you can think about Stokes-Adams syndrome or TIA. If the patient faints within seconds, that's because of postural hypotension or carotid sinus syncope, or it's just bradycardia. And if the patient faints over a few minutes, that's because of hypoglycemia or it's just hysterical fainting. Now, it's very important to ask the patient if they just fainted while they were trying to stand from sitting position. That's because of orthostatic hypotension. Or they were not just changing their position, they were just sitting or standing. That's because of hypotension due to any other cause. Could be carotid sinus syncope or syncope because of tachycardia. Next up, you're going to ask about the duration and frequency of the attacks. If it's brief, that's because of vagovagal or carotid syncope. If it lasts from few minutes to hours, that is because of hypoglycemia or hysterical. However, if there are many attacks over a period of days, that's because of arrhythmia or postural hypotension or just hysteria. Hurrah! Enough of this lecture, just move on to the associated symptoms right away. Okay, so first symptom we're going to see with syncope is just palpitation. So we draw here a palpating kid. Next up, with this syncope mill, we're going to draw three different fire hydrants. The blue one, the yellow one, and the red one. Now the red one is for blood loss, the yellow one is for urine loss, and the blue one is just for fluid loss. Now, if there's excessive blood loss or fluid loss, this can cause postural hypotension and can precipitate syncope. While if there's syncope after micturition, this is called micturition syncope. Next, baby, we draw the owner of this syncope windmill. Here comes Mr. Syncopa with his horse. One thing you'll notice is that he's coughing. I mean straining. So straining or coughing, for example, in the patient with chronic bronchitis or children with the whooping cough can also precipitate syncope. So make sure to take a nice history on cough. And this is what we're going to discuss in our next pulmonary section. Next, you'll see that this horse has beautiful red colored armor plates on his neck. Yes, that is going to represent neck stiffness. Along with this horse is just wearing a headache cap. So this is going to represent about headache. So if there's a patient with a neck stiffness and headache and he comes with a complaint of syncope, that's because of cervical spondylosis. One more thing you'll notice in this horse is that along with neck ache and headache, he's also wearing a beautiful chest plate. Now this is going to tell you about different cardiac conditions that are associated with syncope. For example, in HOCM, which is hypertrophic obstructive cardiomyopathy, aortic stenosis, all these can precipitate syncope. And just before we get through this syncope, here is the last banger. Where is the jerk? Where is he? I think there is a wanted criminal who's just missing from the town and there are banners everywhere. Where is the jerk? Now the jerk really means jerk. If there is syncope with the jerking movements and generalized spasms, without loss of consciousness, that's important, it's going to be hysterical faint. And you see those handcuffs along with that jerk on that banner? Well, that's there to remind you of cough. As I told earlier, that cough is also associated with syncope. For example, in chronic bronchitis or children with whooping cough, they can cough so hard and eventually they'll just faint away. And then finally, we're going to draw these ice flakes around the syncope windmill, which are going to tell you about cold sweating. So must ask about cold sweating in a patient with syncope. This carries great importance for vagovagal and hypoglycemic syncope. So to summarize, if you see a patient with a syncope, you must ask about chest pain on exertion, coughing, micturition, palpitation, headache, neck stiffness, cold sweating, fluid or blood loss, or jerk or spasm. And finally, we move on to Roma and Jones. Welcome to feminism, baby. Now you're going to propose a boy. So as you can see, our Roma is proposing Jones and both look very happy. Now they are here to remind you of rheumatic heart disease. Roma for rheumatic and Jones for the Jones criteria. For example, you're going to ask about arthritis, which is migratory polyarthritis in this case. We're also going to discuss joint pains in our rheumatology section. O stands for heart, and in this case, it could be pancarditis. You'll just get these cardiac symptoms, which are just Peck and P pods with Roma and Jones. N stands for nodules. These are subcutaneous nodules. We'll discuss it in our dermatology section. E stands for erythema marginatum. And S stands for syndrome scoria. That was all about cardiology section. And just as a fresher, what do you say if we just revise these all symptoms? Maybe in just, you know, 5 or 7 seconds? Well, that's fine. I think it's fine. So to summarize, you're going to ask about pain in chest, edema, claudication, palpitation, orthopnea, PND and dyspnea, syncope, and Roma and Jones, which is Jones criteria for rheumatic disease that is typically followed by a strep throat or just skin infections. One thing you might have noticed is we missed our pod, P-O-D. P stands for PND, O stands for orthopnea, and D stands for dyspnea. So we have right now missed these pod, and you know why? Well, that's because this pod is also shared by the respiratory system. So we're going to discuss PND, orthopnea, and dyspnea under the combined shadow of pulmonology and cardiology section. So that was all about CVS. Moving on to the respiratory system, we get CP pod. CP stands for city park, or in this case, it is pain in chest and cough. And what is pod? Pod is PND, orthopnea, and dyspnea. Now, one thing you'll notice is that this is pod, not pods. That's because syncope is missing. We really don't have syncope windmill here. It's just pod. And unlike P pods, it's just a space pod. And you know whose pod is this? Well, it belongs to all hail Vegeta, the prince of no one. I mean, the prince of all Saiyans. And that space pod has actually landed beside City Park. So we have the mnemonic CP pod. C stands for city, P for park, or in this case, C stands for cough, which we'll discuss later. P stands for pain in chest, which we have already discussed in the PEC show, and you'll find that under cardiology section. So without wasting time, if we discuss dyspnea, which is shortness of breath or just breathlessness, along with orthopnea and PND in extension, we can have a lot of causes. For example, respiratory causes, for example, bronchial asthma, COPD, pneumonia, pneumothorax, pleural effusion, pulmonary embolism, pulmonary fibrosis, interstitial lung disease. We can have cardiac causes, for example, pulmonary edema or congestive cardiac failure, or we can have metabolic causes, for example, DKA, we can have chronic renal failure, or we can have psychiatric disorders, for example, hyperventilation syndrome. Now, if you really come across a patient with a shortness of breath, you may want to ask the duration. If it's sudden or short, that's because of pulmonary embolism or pneumothorax. Well, in pneumothorax, the patient is more likely going to be thin, lean, or smoker, and short duration is also associated with bronchial asthma, pulmonary edema, and pleural effusion. Now, on the other hand, if the duration is long, that's because of heart failure or bronchial asthma, chronic bronchitis, or interstitial lung disease. That you may want to know about the onset. If it's sudden, that's because of pulmonary embolism, pneumothorax. If it's gradual, that's because of heart failure or asthma, or simply chronic bronchitis or interstitial lung disease. And if it comes in attacks and the interval between attacks is free, that's because of asthma or maybe hyperventilation syndrome. Then your next job is to assess the severity of shortness of breath. If it's grade 1, 2, 3, 4, just whatever is it, just write it down. Well, that's a great lecture on shortness of breath. Shall we continue to the associated symptoms? Oh yes, of course. So first of all, associated with shortness of breath, you might want to ask about the cough. As our prince of all Saiyan is coughing, now the next question is, what's the significance? Well, good thing you asked. If there's cough with breathlessness and with scanty sputum, that's because of asthma. If it's with mucoid or mucopurulent sputum, that's because of chronic bronchitis. If it's frothy sputum, that's because of acute pulmonary edema. If it's very foul-smelling sputum, that could be because of empyema. Next, we draw elastic bandage around the chest of the prince of all Saiyans. Looks like the prince got his arse beaten badly by a low-class warrior. Here comes Kaioken! So this elastic bandage around his chest is going to tell you about the chest pain. If there's chest pain and breathlessness, better think about the pneumothorax or pulmonary embolism or ischemic heart disease. Next, we're going to draw what? A monkey? A cyan monkey. Is that you, Gohan? Yes, I probably think it's Gohan because it turned into an ape after looking at that moon. And that moon is there to remind you of diurnal variation. And you're going to ask the patient about this. And if they say their breathlessness gets worsened when the night comes, this is because of bronchial asthma. Also, you're going to ask if it gets worsened when you lie down. Well, that's actually orthopnea. And orthopnea can be seen in congestive cardiac failure and COPD. While looking at the moon, you're also going to ask the patient if their symptoms get worse when they try to sleep. Now, this is actually paroxysmal nocturnal dyspnea and is seen in congestive cardiac failure and COPD. Then I'm going to give this monkey a party blower that is going to tell you about wheeze. And remember, all that wheezes is not asthma. Now that looks like the monkey's really celebrating after beating the ass of Prince of All Saiyans. What? Okay. Okay, so when you ask about wheeze, don't forget sneeze because sneeze comes with wheeze. And when sneeze comes with wheeze, there are always skin lesions. And sneezing, wheezing, and skin lesions, these are the features of bronchial atopic asthma. That's getting boring. What kind of destruction is that without any fire? Let's add fire to the scene. Now that's satisfying. A fiery monkey. You know what this fire means? It means fever. And if you get breathlessness with fever, that's because of pneumonia or empyema thoracis. Now it's time to add a hanging, injured kidney. Well, that's only a decoration piece. Well, now we just come back to the Prince of All Saiyans who has just got his arse beaten by a monkey or simply a low-class warrior. And look, see who's anxious here. That's the Prince Vegeta for you. So the shortness of breath can also be because of psychiatric problems, just like our Prince of Saiyans, and it is called hyperventilation syndrome. Okay, so that was about POD, which is just PND, orthopnea, and dyspnea. Now, just as a refresher, the associated symptoms with breathlessness can be cough, chest pain, wheeze, sneezing, fever, orthopnea, PND, or just hyperventilation syndrome or chronic renal failure. Now let's go to the park. Now it looks like this park is heavily decorated with bacterial lamps. Okay, fine. Wait. Why we're here in the park? What are we exactly looking here for? I think we're here for cough. Oh yes, cough. When you talk about the cough, you want to know about the duration of the cough, if it's long-standing or with a recent onset. If it's long-standing, it could be chronic bronchitis, bronchial asthma, or chronic sinusitis, bronchiectasis, pulmonary fibrosis, or if it's recent, that's because of tonsillitis, pharyngitis, tracheitis, bronchitis, tracheobronchitis, or just pulmonary edema. And in that case, this is flash pulmonary edema or just recurrent laryngeal nerve palsy that is also going to give you cough. Then you'll ask about the onset, if it's sudden, if it comes in attacks, or if it's gradual. If you get sudden cough, that's because of acute bronchitis or just flash pulmonary edema or foreign body. If it comes in attacks, that's because of asthma or just pulmonary edema. And if it's gradual, could be pneumonia, chronic sinusitis, bronchitis, pulmonary tuberculosis, lung abscess, and bronchiectasis. Then you're going to ask if there's sputum with a cough. And yes, if there is sputum, you're going to ask about the color of the sputum, odor, quantity, character, and just relation to the posture. Now, colors, we have a lot of flavors in the sputum. It could be frothy white, that is in pulmonary edema. If it's rusty, that is in pneumonia. If it's yellowish, that is because in pyogenic infections. If it's greenish or greenish blue, that is because in Pseudomonas or just in bronchiectasis. If it's brick red currant jelly, that's because of Klebsiella. If it's just like anchovy sauce, that is because of ruptured amoebic liver abscess. If it's black, this is because of coal miner's disease. And if it has blood, or you can simply say hemoptysis, then it can have a lot of causes. For example, acute bronchitis, chronic bronchitis, lung carcinoma. We can have ABPA. We can also have tuberculosis. And just like that, pulmonary embolism, AV malformation, platelet disorder, bleeding disorders. We can have mitral stenosis, or we can simply have vasculitis. After color, you're going to ask about odor. And if it's very, very bad, foul smelling, that's because of lung abscess and bronchiectasis. Then you will ask about the quantity. If there is just scanty sputum, that is seen as asthma, pharyngitis, bronchitis, tracheobronchitis. If there is moderate, that is chronic bronchitis or resolved pneumonia. And if there are tons of sputum, very large quantity, that's because of bronchiectasis or lung abscess. Going to ask about the character of sputum. Is it frothy? Seen in pulmonary edema. If it's mucoid, this is seen in bronchial asthma. If it's mucopurulent, that is seen in chronic bronchitis. And if it's purulent, only pus, you're going to see this in bronchiectasis and lung abscess. Then you're going to ask the relation to the pus. Okay, so we're going to discuss it later. Right now, it's enough. Just remember that color, odor, quantity, character, these are all associated with sputum. But what if there's no sputum? If there's dry cough, that is seen in most of the respiratory diseases, interstitial lung diseases, pulmonary fibrosis, dry pleurisy, recurrent laryngeal nerve palsy. Finally, we can enter into the park. Wait, there is an officer in the park, and that officer is showing me the handcuffs. Is everything fine, sir? So these handcuffs are going to tell you about cuff, which we have already discussed a lot in detail. I think the officer is investigating something, and that is just like this greenish discharge. And that greenish discharge is in front of the officer, right, coming through his nose as well as on his back side. The discharge that's coming through his nose is actually sputum, which we have already discussed in detail. You have to ask about the color, odor, quantity, character of the sputum. And what about the discharge that is on the posterior side? Well, that's actually postnasal discharge. And this postnasal discharge is seen in acute and chronic sinusitis. Then in the park comes weight out of nowhere. Actually, this is weight loss. So if you see a patient with cough, you might want to ask about weight loss. And in this case, it's going to be significant weight loss. Now, this is seen in bronchogenic carcinoma, all chronic respiratory infections, for example, tuberculosis, lung abscess, and bronchiectasis. Whoa, monkey, just hold on. Looks like this monkey has caused a lot of destruction, not only to the Prince of all saints, but also to the city park. And that park is now on fire as well. And you know what that means? That means fever. So if there's a patient with cough and fever, you might think of tuberculosis and all respiratory infections. And now what kind of park is that without any tree or plant? Let's add some more. Here we draw some dandelion, which are going to tell you about dust, fumes, pollens, trees, and all the triggers of asthma. So you have to ask your patient about all these triggers, and if they are positive, including animal fur, parrots, pigeons, and all these triggers, you're just going for asthma. Next in the city park, we're going to draw a calisthenic athlete. And you know what? She is having a very different posture. So now here we're going to discuss about the relation of sputum to the posture. Now when the patients say when they turn to the one side and they have increased sputum production, that means the disease of the opposite lung. When they say they get more sputum production when they lean forward, that is because of disease of base of lung, for example, lung abscess or bronchiectasis. And when they say they get more sputum when they wake up early in the morning, that's because of lung abscess or bronchiectasis. So this relation of sputum to the posture is very important, and this is represented by this calisthenic athlete in an unique posture. Whatever is it. And now we're going to give her elastic bandage on the chest. That is going to tell you about the cardiac pain, and to learn more, you can always go to the cardiac section, where you'll find different bodybuilders in the pack show. Now, if there is chest pain along with sputum production and that chest pain is pleuritic, that is because of pleurisy due to lobar pneumonia or just pulmonary infarction. So here the character of chest pain is really going to separate different types of chest pains. If it's burning, that's because of GERD. If it's just discomfort, that could be because of pericarditis. Pericarditis can also present with pleuritic chest pain. But if there's crushing or heaviness with the positive Levine sign, this is going to be angina or MI. But still be very careful. And just as a pro tip, remember that cardiac pain can also mimic GI pain and can also present as burning pain. Let's go back to this calisthenics lady, and she is just now blowing hard. Well, that's because of breathlessness. And you know what? This breathlessness is going to take us back to the part where we have PND, orthopnea, and dyspnea. Now, if there's sputum production along with breathlessness on exertion, PND and orthopnea, that's because of left ventricular failure. And if there's swelling of legs as well, this is strongly indicating left ventricular failure, and if there's no swelling, you might need to add COPD under your differential if the patient is chronic smoker. Now in the city park, we're going to add, oh, that's cute, a cute little baby. And that cute little baby is with the party blower. And that party blower is going to tell you about wheeze. Remember, all that wheezes is not asthma. It could be COPD, it could be heart failure, later stage lung cancer. So right now, we're just looking at the combination of wheeze and sputum production. Now, if there is wheeze with the sputum production, this could be bronchial asthma or pulmonary edema if it's frothy sputum or chronic bronchitis. Oh my god. Finally, this respiratory system is done. So very, very done. How about the recap? What do you say? So the recap is very brief. We learned about the pain in chest, cough. Now this cough is associated with wheeze, breathlessness, chest pain, fever, postnasal discharge, nasal discharge, weight loss, dust, fumes, or relation to the posture, infection, and we learned about orthopnea, PND, and dyspnea. So that's all from the pulmonary section. Now let's move on to the gastroenterology or just GI system. So what do we have here? We have here is an advocate who was shot dead beside a stool. Yes, stool. That's for sitting. And the reports also say that the name of the advocate was Jamal Pandu. Yeah, I know it's a made-up name. Sounds fake, but okay. Anyway, now what are we going to discuss in this scenario is appetite, dysphagia, vomiting or hematemesis under the same heading, jaundice, dyspepsia, edema, ascites, distension of abdomen, and stools in detail. That include constipation, diarrhea, flatus, melena, and so and so. Sit tight and get ready because we embark on a journey to investigate who shot our advocate Jamal Pandu dead beside stools. So while we arrive at the crime scene, we find what? What is this? It's a machine? It's a tanker? Or what is it? Well, we don't know what is it. We just call it machine. And I think this thing shot our advocate dead. So to know more about this machine, we just fill up the colors. Now we know that there are two input terminals on the top, while there are three different output terminals at the bottom. And this is just resembling our GIT system. You know, just like you eat things, your stomach processes things, and then you just defecate them out. So let's crack this thing down, shall we? So one of the input terminals is going to represent dysphagia, and the other input terminal is going to represent about the vomiting or hematemesis. I know it's an input terminal, but when things go wrong, the output starts coming out of the input channel. So if we talk about the dysphagia, which is the first input channel, dysphagia simply means difficulty in swallowing. Now, different causes are there. There are oropharyngeal causes, esophageal causes, and functional, which is known as globus hystericus. Now, this sudden onset is very important. This is significantly related to the foreign body impaction. Then it's very important to ask about the nature of dysphagia. For example, it could be progressive or non-progressive. If it's progressive, the patient is going to complain that they started dysphagia with solids, then they shifted to the semi-solids, and now they're at liquids, and now they can't even take liquids. And it's just getting worse with the passage of time. This is because of carcinoma of esophagus or peritonsillar abscess, which is also known as quinsy, or bulbar palsy, or just pseudobulbar palsy. Then you're going to ask the patient, what is your problem? What's wrong with you? Yes, you're really going to ask it. You will ask them where the food seems to stick. Now, if they say behind the mouth or throat, that's because of tonsillitis or quinsy, or if they say behind the cricoid cartilage, that could be because of stricture or esophagus or Plummer-Wilson syndrome, or could be neuromuscular disorder, for example, pseudobulbar palsy or palsy. And if they say that the food sticks behind the sternum, that could be because of stricture or peptic esophagitis or just achalasia. Then you're really going to investigate about the type of food. If the dysphagia is with a solid food, that is because of stricture or growth of esophagus or foreign body. achalasia or peptic esophagitis. And if the patient says they cannot take liquid, that is because of neurological or neuromuscular disease. Now, if they say they have a feeling of lump in the throat and they have it checked multiple times but there's really nothing, that's globus hystericus. Next, you're going to ask if it's painful or painless dysphagia. If it's painful dysphagia, that is because of tonsillitis, peritonsillar abscess, which is quinsy, or just peptic esophagitis. Finally, you're going to ask about the progression. If it's intermittent, that's because of myasthenia. If it's not changing over the years, that's because of achalasia or Plummer-Vinson syndrome. And if it's getting worse within weeks, that's because of carcinoma esophagus. If it's getting worse within months, that's because of benign stricture. And if it's getting worse in few days, that's because of bulbar or pseudobulbar palsy. Now that's enough lecture on dysphagia. Let's move on to the associated symptoms. First of all, we have heartburn. That is represented by the burning cannon input. Now, if the patient has heartburn, or you can say retrosternal burning along with dysphagia, that is most likely because of peptic esophagitis. Next, what we have here is a red handkerchief that is hanging with a pole. And this red handkerchief used to be our symbol for sore throat. Now, if there's a patient with a sore throat, fever, and dysphagia, that is most likely because of acute tonsillitis or peritonsillar abscess, which is quinsy. Next, this machine has also two security cameras, and one of the cameras is just down. And that is representing drooping of the eyelids. When there's drooping of the eyelids along with dysphagia, this is going to be myasthenia gravis. And the patient is going to tell you that in the beginning of the day, everything is fine. As soon as the day passes, they get symptoms. Next, we have another advocate who came here for the inquiry of the death of Jamal Pandu, and his name is Kamal Pandu. You know one thing about Kamal Pandu? He's having a flame bandana, which is going to represent fever. So our advocate is with the fever. Now that is really going to tell you about acute tonsillitis and peritonsillar abscess if they are associated with sore throat as well. If there's no sore throat, just fever and dysphagia, that is most likely because of carcinoma. Looks like Kamal Pandu found the culprit and hanged him till death. And the culprit is just like, he's having slurred speech. So slurred speech that he can't even ask for help? Bro, even if you ask for help, it's useless now. So when there are complaints of nasal regurgitation of fluids, choking, slurred speech, that is because of neuromuscular diseases, for example, bulbar palsy or pseudobulbar palsy. Next we have is a skinned lion, and that skinned lion is going to tell you about the tightening of the skin as seen in scleroderma or the Raynaud's phenomena. So if there's dysphagia with the tightening of skin, that is Raynaud's or scleroderma. So now to make sure that the gallows stay at their place and don't get displaced, we add some weight. Now in this case, this is weight loss with an arrow going downward. When there's weight loss with dysphagia, that is because of malignancy or any other significant obstruction. You know, fun fact about this culprit? Before he was hanged to death, his hands were secured with the handcuffs. So these cuffs are very important, just like the combination of dysphagia and cough. Now if there's recurrent cough, that can cause aspiration pneumonia. Next, to add more to this dysphagia, we can always go to the Appetite App Store. To find out more, head over to our Appetite App Store main factory outlet and the Constitutional Symptom segment. Now, if the appetite is reduced with dysphagia, that could be because of carcinoma of esophagus. Next, we come back to our advocate, and while he looks at the machine, he's just so surprised and he's like, the what? That is called the real anxiety. Now, if there is dysphagia with anxiety or depression, that is because of globus hystericus, and the patient is constantly telling you that there is something in their throat while they already spent a lot of money in their checkups and they have got it checked multiple times, but there's nothing, but they're still complaining something is stuck behind the throat. And that's all about dysphagia. Just one more thing, ask about the past history of suicidal attempts with corrosives, as the corrosives can really form strictures. Next up, let's explore the second input terminal. Is the terminal when things go really wrong and start coming out. So it's no longer an input terminal. That's vomiting. So if we just talk about vomiting, it has a lot of causes. For example, gastroenteritis, peptic ulcer, viral hepatitis. We can have endocrinological disorders, for example, Addison's disease, diabetes, where the patient presents in the diabetic ketoacidosis. We can have vomiting in pregnancy, obstructive lesions, for example, pyloric stenosis, intestinal obstruction, paralytic ileus, psychogenic vomiting. We can also have drugs that cause vomiting, for example, digoxin, iron, potassium chloride, opiates, estrogens, and bronchodilators. And we can have other different causes, for example, Meniere's disease, intracranial pressure, migraines, colics that include renal colic, biliary colic, intestinal colic, or any other febrile illness. Now, when you see a patient with vomiting, you're going to ask about the frequency, how many times in 24 hours. Then you're going to ask if it's projectile or non-projectile. The only thing that differentiates between these two types is nausea. The projectile vomiting is seen in intracranial pressure and pyloric stenosis. Then you will ask about the timing of vomiting. If it's early morning, that could be because of pregnancy, alcoholism, uremia, chronic bronchitis, and sometimes psychogenic vomiting. Now, one more important thing is relation to the meals. Now, if it's immediately after the meals, that's because of anorexia nervosa, or something just can be wrong with the throat. If the patient just vomits half hour after taking meal, that's because of peptic ulcer, and if there's no relation to the meal, that is because of endocrine disorders. Else are you going to ask in a patient with vomiting? Well, you have to ask about the contents. They really tell you a lot about what's going on. If there are food particles eaten up to 2 hours ago, that's because of gastritis, gastroenteritis, peptic ulcer, or endocrinological disorders. If they're partially digested food eaten up to 24 hours, that's because of pyloric stenosis and small intestinal obstruction. We'll ask about the color of the vomitus. Now, if the vomitus is yellow, that's because of HCl and seen in pyloric stenosis or obstructive jaundice. If it's greenish, it is containing bile. And if it's coffee ground, that is just hematomasis, and it could be because of ruptured esophageal varices, bleeding peptic ulcer, which is the most common cause, gastric erosion, gastric carcinoma, uremia, and sometimes bleeding disorders. And then you're going to ask about the smell. If it's just normal vomitus smell, that's normal. If there's smell of some fecal material, that's because of fistula or paralytic ileus. If it's putrid, that's because of bacterial overgrowth seen in fungating gastric carcinoma. And now, please, that's enough of the lecture. Let's just go with the associated symptoms. Can we just stop here? First associated symptom of vomiting is pain. You have to ask the patient if they have any pain in the right hypochondrial region, or just burning or cutting epigastrium pain, or anywhere pain in the abdomen. And to remind you of the pain was peptic ulcer. Next, we can also ask the patient about the history of jaundice. If it's positive, that's because of viral hepatitis or acute cholecystitis or pancreatitis. Now remember, this jaundice vomiting can also be associated with the pain in the right hypochondrium region. Let's see what else this machine is having for us. She's having an injured hanging kidney with a bow tie. So that means chronic renal failure can also present as vomiting. That's because of hyperuricemia. And sometimes thyrotoxicosis can also present as vomiting. However, this is not a main presenting complaint. What is it? It's just gonk coming out of this machine? Or is it just diarrhea? Yes, it looks like diarrhea. There's vomiting and diarrhea, that is because of viral gastroenteritis or bacterial gastroenteritis, also seen as diabetic ketoacidosis. We just call it diabetic diarrhea. And sometimes in Addison's disease, we also get the diarrhea. To help you remember the causes of diarrhea besides bacterial or viral gastroenteritis, we're just drawing this jar of sugar candies along with this Addison logo, which is Addison's disease. Now, as you can see in the second input terminal, there is a secondary pipe that is just obstructed or constipated or blocked, whatever is it. So there's obstruction and blocking. Now, if there's constipation, there is vomiting. What are the causes of constipation? Well, hypercalcemia and intestinal obstruction can cause constipation, and constipation can ultimately cause vomiting. And now we're drawing this lady and she's pregnant. What? Anyway, she's trying to look the machine from the other side, and guess what? she's just looking at the machine and she's not listening to the machine. She's just wearing those red headphones. It means something is wrong with the ear. Either it's deafness or attacks of vertigo, as seen in the Meniere's disease. So, in the Meniere's disease, you get deafness and vertigo along with vomiting. And that's all about vomiting. Just one more thing, ask about the aggravating factor. If they say they feel bad after eating spicy food, that's because of peptic ulcer. And if they say they cannot eat meat or chicken, that's because of carcinoma of stomach. And if they are emotionally upset, that's psychogenic vomiting. And of course, the relieving factors are going to be milk or antacids or the sucralfates or something like that. So that's all about vomiting. Now let's talk about hematemesis, which is just blood in the vomitus. Now this hematemesis has many common causes. For example, esophageal varices, gastric erosions, Mallory syndrome, Boerhaave syndrome, or we can have peptic ulcer, gastric carcinoma, and bleeding disorders. Now one thing you'll do about hematemesis is just ask the color of the vomitus. If it's dark red or coffee ground, that's because of slow bleeding. If it's bright red, that's because of recent bleeding or massive bleeding. And you can also ask about the quantity of blood. Ask about NSAIDs, steroids, alcohol, or previous history of jaundice or ascites that can lead you to liver cirrhosis. And to talk about the associated symptoms, we have anemia and jaundice. Now, this anemia is represented by these red signals that suspiciously look like RBCs. And for the jaundice, we give yellow paint to the posterior part of this machine. Now, if the patient is anemic, he's going to come with the complaints of palpitations, shortness of breath, fatigue, headache, and so and so. And if the patient is with jaundice, ask about ascites, appetite, lymphadenopathy, fever, rigors, and pain in right hypochondrium. Okay, so besides anemia and jaundice, what else are you going to ask the patient? Well, you're going to ask about the heartburn. So I'm going to represent the heartburn by this flamey butt of the machine. Well, really? Your heart lies in your butt? Anyway, it's heartburn. Now, when you get heartburn with hematemesis, this is peptic ulcer disease, the most common cause of hematemesis. Now you see there's a lot of water coming out of this machine. It's the fluid overload. So ask about the ascites in a patient with hematemesis. These are the just patients of DCLD. And to learn more about edema and ascites, head over to the ascites water tank in the cardiology section. Wait. This machine can also bleed. Is that blood coming out or some chemical toxin? I don't know. Seems like blood to me. So in the patient of hematemesis and melena, keep bleeding disorders or bleeding diatheses under your differential. Ask about a history of gum bleed, nose bleed, skin bleed, petechiae, rashes, or something like that. And if that's from childhood, it's surely going to be some hereditary disease. Next, we draw this bald man who's just hanging around the dead body of our advocate Jamal Pandu. I think you're the culprit. And as you know, this is very suspicious, so he's surely hiding something under his cap or under these elastic bandages around his abdomen. I know, baby, there's something fishy about you, and you just can't escape. What? You get arthralgia as well? Now, if we talk about the abdominal pain, that's in the left hypochondrium, and that is seen in the patient with cirrhosis. Now we're left with two more pains, that is headache, pain in head, and joint ache, that is arthritis. Now, there's no direct relation of hematemesis with headache or arthritis or joint pains, but this is just an indirect way of asking your patient if they are taking some potent NSAIDs, which can cause gastric erosion and hematemesis. However, joint pain is an exception to this rule and can be seen in the patients with hemophilia and they present with hemarthrosis. Oh my god, look what this suspicious man found. He found skull with broken bones around. Now these round broken bones suspiciously look like lymph nodes. So ask your patient if they appreciate some nodules in the cervical, groin or axillary region. These are actually lymph nodes. And what about bones? These bones are going to represent bone pains for which our patient is chronically taking NSAIDs. So this is just an indirect way of asking drug abuse. You know why these bones are crushed into round pieces? That's because something heavy fell on it, and that's weight. And to be more specific, a weight with an arrow going downward, which is weight loss. If there's hematemesis and weight loss, better think about gastric carcinoma. What else are you going to find? You'll find anorexia and asthenia as well. So if you see weight loss, anorexia, asthenia, and hematemesis, go for gastric carcinoma. Now it's time to draw a scarecrow. And it's not just a simple scarecrow, it's a jaundiced scarecrow. This scarecrow is wearing a yellow coat that is going to represent jaundice. And to add more to the scarecrow is fastened by the use of elastic bandages from left and right sides. So that is going to represent the pain in right hypochondrium and pain in left hypochondrium. Now the whole story is very simple. If there's jaundice and pain in right upper quadrant, that is either because of liver or because of the hepatobiliary tree. Now, the liver causes include viral hepatitis or drug-induced hepatitis, and the pain is colicky. That is because of choledocholithiasis. Or if there's jaundice with the pain in the left upper abdomen, that is because of cirrhosis of liver or hemolytic jaundice. Now, to talk about the jaundice, we get prehepatic, hepatic, and posthepatic. Prehepatic are the hemolytic causes, for example, autoimmune, thalassemia, glucose 6-phosphate dehydrogenase deficiency, or blood transfusion. The hepatic causes include viral hepatitis, toxic hepatitis, infiltrative diseases, for example, Wilson disease, hemochromatosis, or congenital hyperbilirubinemia, for example, Gilbert syndrome, Dubin-Johnson syndrome, or Rhodes syndrome. And if we talk about the posthepatic causes, we get the choledocholithiasis, cholangitis, cholestasis, and malignancies, for example, the carcinoma of head of pancreas or carcinoma of ampulla of Weber, etc., etc. Now, if you see a patient with jaundice, what are you going to do? You're going to ask the duration. If it's long-standing for years or just recent. If it's for years, it's because of familial hyperbilirubinemia, and if it's recent, that's because of infection or toxic hepatitis or just hemolytic jaundice and obstructive jaundice. Next, you're going to ask about the onset. If it's sudden, that's because of hemolysis or a sudden stone impaction in the bile duct. And if it's gradual, that's because of infective diseases or just drug-induced hepatitis. Next thing is to ask about the colors of poop and pee. Now, the urine is going to get dark in all types of jaundice, while the color of stool changes to clay color in just obstructive jaundice. Next, we draw again an appetite app store, and this time near this jaundice scarecrow. So this means when you see a patient with jaundice, must ask about their appetite. To learn more about this appetite app store, head over to our constitutional symptoms segment where the factory outlet of appetite app store is present. Just as a refresher, an appetite can have different flavors. For example, it's poor, it's intermittent, or it's progressive. If the appetite is poor with the jaundice, that's because of viral hepatitis or drug-induced hepatitis. Now, if the appetite is intermittent, that is seen in hemolytic crisis, or if there is a stone in CBD, or just in the carcinoma of ampulla of Weber. And if the appetite is progressively decreasing, that's seen in the carcinoma of head of pancreas. So these are the relations of different flavors of appetite with the jaundice. That's a lot of detail about appetite and jaundice. I wish I could burn this whole thing to hell. Oh my god, oh my god, oh my god, there is fire. Burn in hell. Everything is on fire. It means fever. Now, this fever can have different combination with the jaundice. For example, if there's first fever followed by jaundice, that's because of viral hepatitis. Or if there's intermittent fever with rigors during the period of jaundice, this is cholangitis. Or if there's fever with rigors at the onset of jaundice, this is hemolytic jaundice. Oh my god, the fire is catching almost everything, including that tiny little duck. And what about her eggs? Well, this is not a duck, this is just a swan, and it's a swan from that toxic pond in the constitutional symptom segment. And this duck is here to remind you that you must ask about the rigors with the fever. You know the other causes of rigors? Toxemia, septicemia, and malaria. Well, that swan is right from that toxic pond. And you see her eggs? These eggs are suspiciously looking like lymph nodes. These lymph nodes are going to represent the carcinoma of head of pancreas, or ampulla of Weber, or just carcinoma of CBD. Now that was all about jaundice. As a quick recap, you're going to ask about pain in right hypochondrium or left hypochondrium region, or fever or rigors or appetite or lymph nodes. Next, we're going to talk about abdominal distension, and we're going to represent this with a distended tent that looks like abdomen. Now, this distended tent is supported by 4 different weights. So, in a distended abdomen, you're going to ask about weight loss. And one more thing, this abdominal distension is quite different from ascites. Now, ascites is just fluid, and abdominal distension is a big category. It can have other different causes, including ascites. Now, it can have obesity, pregnancy, ascites, intestinal obstruction, or ovarian cyst. So we have different Fs. F for fat, F for fetus, F for fluid, F for flatus and feces, and F for fibroid. Now, if you see a patient with abdominal distension, you're going to ask about the onset. If it's sudden, it's acute intestinal obstruction. You'll ask about the progression. If it's localized, it could be pregnancy, it could be intestinal obstruction, intestinal TB, malignant ascites, or ovarian cyst. If it's starting from abdomen and progressing to legs, that's because of cirrhosis. If it starts from legs and moves to the abdomen, that's congestive cardiac failure. And if it starts from the lower eyelids and face and causes puffiness, including complaints of puffiness of face when the person wakes up, and this progresses from face to the abdomen and feet, that's because of nephrotic syndrome. Next, you'll ask about pain. If it's painful, it's intestinal obstruction or pyogenic infection, or it could be tuberculous ascites or malignant infiltration. If painless, could be obesity, pregnancy, ovarian cyst, or some transudative ascites, for example, ascites because of liver, kidney, or heart. Next, as we already discussed about the weight loss, if there's weight loss and abdominal distension, along with change in bowel habits, that's because of malignant ascites due to GIT malignancy. One more thing you'll learn about this stent is that it has an outlet, and that is obstructive. That's why we have colored it in red. Now, this red outlet is going to represent the absolute constipation and intestinal obstruction. So we're really going to see the features of intestinal obstruction that include vomiting, pain in abdomen, absolute constipation, inability to pass the flatus, and abdominal pain. Next, beside this distended tent, someone has enjoyed a lot of these cola drinks and just thrown away these Pepsi cans around. Seriously, that's very bad. Anyway, these Pepsi cans are going to tell you about dyspepsia. Now, if there's dyspepsia along with abdominal distension, that is perforated ulcer. See what we got? Just like the last time, another scarecrow, and that one is also in yellow, which means jaundice. And again, just like the last time, it's also fastened with elastic bandages on the right and left side, which is just going to tell you about the pain in left hypochondrium region or the pain in right hypochondrium region. Now, if there's jaundice and abdominal distension, it's a liver cirrhosis. Now, if there's pain in the left hypochondrium region along with abdominal distension, this is splenomegaly because of, again, liver cirrhosis. And for the pain in right hypochondrium region and abdominal distension, it is liver itself. Oh no, just like the last time, this tent is again on fire. Burn in hell. This fire is going to represent the fever. If there's abdominal distension with fever, that could be because of tuberculous ascites or peritonitis. And you know what? Because of the fire, the lady has come out of the tent. Actually, it's not just a lady. It's a lady plus a baby. You know that? She's just carrying 2 lives at one time. So that lady is just pregnant. Must rule out pregnancy when you see abdominal distension. This is generally a young lady who complains of this gradual painless abdominal distension starting from lower abdomen associated with amenorrhea, morning sickness, and fetal movements. And now when the tent burns, this lady just comes out, saves 2 lives, and is looking at her own tummy and see if the child is really fine. You're going to be a beautiful mother, just beautiful as your necklace. And you know what? This beautiful necklace is suspiciously looking like lymph nodes. So if a patient comes with abdominal distension and lymphadenopathy, better think of some carcinoma or just malignant infiltration. Then we draw a pad, and this pad is going to tell you about amenorrhea. If there's amenorrhea with the abdominal distension, could be pregnancy, could be ovarian cyst, which is also known as Meek syndrome, and sometimes it's also seen in tuberculous ascites, cirrhosis, or just nephrotic syndrome. Next, we draw this edematous water tank to represent edema, and to know more about edema, head over to our cardiology section to learn more. Next, there is a Pepsi truck, and the driver is just trying to deliver the Pepsis to the outlet. And you know what? For the promotion of the brand, we also got here a hot air Pepsi balloon. Now, this Pepsi is going to represent dyspepsia, which is just discomfort in the upper abdomen, could be associated with flatulence, heartburn, nausea, vomiting, and the common causes include ulcers, could be gastric or duodenal, IBS, chronic cholecystitis, chronic pancreatitis, or just appendicitis or gastric carcinoma. Now, when the person says there's a discomfort in the upper abdomen, better start taking the history of a pain. You have to cover onset, duration, intensity, progression, associated factors, aggravating factors, and relieving factors, along with corrector, radiation, relationship to food, timing of pain, and periodicity. If it's epigastrium or left hypochondrium, it's gastric ulcer. If it's the right part of epigastrium, that's duodenal ulcer. If it's right iliac fossa, that's appendicitis. If it's right hypochondrium, that is chronic cholecystitis. If it's diffuse over the whole abdomen, that's because of non-ulcer dyspepsia or irritable bowel syndrome. Then you'll ask about the character of the pain. If it's cutting or burning, that's simply peptic ulcer. If it's colicky, that's because of chronic cholecystitis or just appendicitis. If it's dull, this is pancreatitis and the patient is going to present in Mohammedan's prayers position. Now, if the pain radiates towards the right shoulder, right scapula or interscapular region, this is going to be biliary colic or chronic cholecystitis. If it's penetrates through the back, this is perforated duodenal ulcer or just pancreatitis. If the pain is at McBurney sign, this is appendicitis. If the food causes pain, this is gastric ulcer. If the food relieves pain, this is duodenal ulcer. If there is no relation, this is non-ulcer dyspepsia. Now, just like this relationship with the food, timing is also very important. If the pain occurs half hour after meal, it's gastric ulcer. 1.5 hours after meal, this is duodenal ulcer. Pain in early morning when the stomach is empty, that's duodenal ulcer. And if there's constant pain and that pain increases with meals, this is gastric carcinoma or just penetrating peptic ulcer. If there's just no definite relationship of timing of pain to the meals, that's seen in chronic cholecystitis, chronic pancreatitis, or appendicitis. Now, one more thing about peptic ulcer is that there's periodicity. In the peptic ulcer, you get episodes, each lasting from 7 to 14 days and 2 to 6 times a year. Okay, so enough of this lecture. Let's move on to the hot air balloon. Now, when you see this hot air balloon, you see it's already tied with a weight. And that's the symbol for weight loss. That's because of gastric carcinoma and sometimes in peptic ulcer. Then you'll also notice that this balloon is on fire. That fire is actually heartburn, and if there's dyspepsia with a heartburn, this is reflux esophagitis or peptic ulcer. Wait, emergency, it's an ambush. The skeleton dead army has attacked the Pepsi balloon and the Pepsi truck. Help! You know what? The skeleton is trying to hijack a hot air balloon. Whoa, man, what a choice. And as you can see, the skeleton took excitement to the next level and got this balloon punctured. Stupid man, you're just digging your own grave. Oh, wait. I forgot. You're already dead, right? So this air coming out of balloon is just flatus. Now, if there is passage of flatus with blanching and blotting and dyspepsia, this is going to represent non-ulcer dyspepsia, chronic cholecystitis, chronic pancreatitis, appendicitis, and peptic ulcer. You know, after making a punch hole in balloon, the skeleton is now just sad, cursing himself, thinking about life decision, life choices. Oh my god, why am I here? I should die for the second time as well. Now he's taking anxiety and depression very seriously. So just like that, if there's dyspepsia with depression or anxiety, and with morning nausea without any significant weight loss, this is non-ulcer or just functional dyspepsia. Oh my god, the ambush is real. The truck has been hijacked. It's the skeletal army. And you can see I've drawn the main leader of the skeletal army onto the bonnet of the truck, and he's with a flag and a beautiful shield. This shield has a beautiful alternating pattern, black and white, just like alternating diarrhea with constipation. So if there's dyspepsia along with constipation alternating with diarrhea and scanty stools containing mucus, this is IBS. That's okay, but what about the flag? What does the flag mean? Well, for your information, the flag has skull and bones and just crushed bones that look like lymph nodes. So you're going to ask about bone pains and lymph nodes. Now, the lymphadenopathy is because of the gastric carcinoma, and the bones, they're just an indirect way of asking the patient if they're taking any NSAIDs. And finally, one of the skeletons from the skeletal army was missing, and he's just here. He's jumping into the truck to steal some drinks. And now if you look at the stool, you realize this is a yellow stool, and a yellow stool stands for steatorrhea. Now it's time to go back to our advocate who was shot dead beside the stool. One thing you'll see is that this big, giant, weird machine, yes, it has 3 different output terminals. One of the terminals is just releasing black toxic gas along with these black stools. So the first output terminal is going to represent melena. The second output terminal is going to represent diarrhea, and the third output terminal is going to represent constipation. These stools are really tarry, sticky, and semi-solids, just like this black gas coming out of first output terminal of the machine. Now, this melena is really associated with hematomasis, and just like all other diseases, we can always talk about associated symptoms with the melena. First up, I'm going to draw a lot of blood because our advocate was shot dead and he's bleeding so badly. And then you'll realize there's something coming out of blood that looks like red blood cells or something. Oh, yes, that's anemia. So, in a patient with complaints of melena, you're going to keep bleeding diathesis in the back of your mind, and you're also going to ask about the symptoms of anemia. For example, palpitation, tachycardia, myalgias. One more pro tip: while you go for bleeding disorders, ask the patient if they appreciate any bleed from the gums, nose, skin, or do they have petechiae or rashes or something like that. Then we're going to give this advocate an elastic bandage on its knee joint that is indicative of arthritis. Now, this arthritis is just an indirect way of asking the patient if they're taking any NSAIDs. You know, one more fun fact about our advocate Jamal Panda. He was just dragged out of his tent and shot in an open ground. So here we draw another tent. This is going to represent the distended abdomen, and this tent is supported by 4 different weights, which are going to represent weight loss. Next up, we draw the wife of Jamal Pandu. This is Jamila Pandi. She has just come to know about the death of her husband. Ah, pity. One thing you'll notice is that this lady is wearing a beautiful necklace, and this necklace is suspiciously looking like lymph nodes. Now you must ask your patient about lymphadenopathy, and if they're positive with the melena, better go for carcinoma. You know that this lady is also holding a can of Pepsi? Now that's for dyspepsia. If there's melena and dyspepsia, that is peptic ulcer. That's enough for the advocate. Until now, we haven't found anything, so we just move to the machine. Now we move to the second terminal of the machine that represents diarrhea. Now if we really talk about the diarrhea, it's just increase in the frequency or the fluidity of the stools. So as you know that the diarrhea can be in different flavors. So first of all, we're going to represent the bloody diarrhea with these red colors, followed by a viral diarrhea or the watery diarrhea with the blue colors, and finally the diarrhea with the mucus or pus with the white color. Now there are really different causes of the diarrhea. For example, there could be infectious diarrhea by the protozoa, bacteria, or the virus. It can be associated with the IBS or IBD or just endocrine disorders, for example, Addison's disease, hypothyroidism, diabetes, in which we call it diabetic diarrhea, or just tumors, for example, villus adenoma, colorectal carcinoma, or carcinoid tumors. And then there are some drugs, for example, antibiotics, antacids, magnesiums, laxatives, or some just antihypertensive drugs or just cholinergic drugs. Then there's some miscellaneous diarrhea, for example, traveler's diarrhea, diverticulitis, roundworm, tapeworm, hookworm, just worm infestation, or some psychogenic diarrhea. Next thing, you're going to ask about duration and cause. If it's gradual, that's because of malabsorption syndrome, endocrine diseases, or just IBS. If it's with acute onset and settles in a few days, that's because of viral gastroenteritis, bacillary dysentery, or amoebic dysentery. It can also be food poisoning or traveler's diarrhea. And now if it's with acute onset and long course, that's because of ulcerative colitis, Crohn's disease, or just diverticulitis. Now, one thing you'll realize is that the second terminal is having a beautiful pattern: red, blue, yellow, white. Red, blue, yellow, white. So this pattern is here to remind you of that you're going to ask your patient about the pattern of the diarrhea. So what is the pattern of diarrhea? If it's alternating with constipation, that could be because of IBS or excessive use of laxatives or carcinoma of colon or diverticulosis or just intestinal TB. On the other hand, if it's continuous, that's because of Crohn's disease, laxatives, or intestinal fistula. If intermittent, go for psychogenic diarrhea or just malabsorption syndrome. Ask about the frequency of stools, character of the stools, in which you're going to ask about the quantity, consistency, and the presence of mucus or pus or blood. Now it's time to learn about the associated symptoms with the diarrhea. So here we draw 2 different dogs. As you know, one of these dogs is an itchy dog who is just itching, while the other dog is just, struggling with poop. He's just stressed and he's having cramps in his stomach and tenesmus. Yes, so tenesmus, cramping, and stress. So in a nutshell, one of the dogs is just itching, while the second one is struggling with the poop. So if there's itch with the diarrhea, that's because of dermatitis hepatiformis. And if there are abdominal cramps that are relieved by defecation, this is small intestinal disease. And if there are abdominal cramps that are persisting even after defecation, this is large intestinal disease. Second thing is tenesmus. Now, it is seen in the inflammatory disease of the bowel. For example, amoebic dysentery or bacillary dysentery, ulcerative colitis, Crohn's disease, and anorectal carcinoma. Third, you'll notice that this dog is struggling a lot with the diarrhea. Now, he is just in a lot of stress. So the stress with the diarrhea is because of the nervous diarrhea. This diarrhea is usually self-limiting and consists of watery stools. Now we just draw family members who have come through a long way to see this machine, and they have come with a personal photographer. Now in this whole scenario, family history is very important. For example, if you find a case where the whole of the family members just hanged out for a picnic or party and all of them got the diarrhea, that's just food poisoning. Now I don't want this family to be a happy family. Let's give every member a single unique disease. Let's start with the kid and we give him rash. So the skin rash with the diarrhea is just going to tell you about ulcerative colitis, Crohn's disease, or just dermatitis hepatiformis. So that was all about the first child. What about the daddy? Let's give daddy some arthritis and a brand new shirt from the Edisons. Or just in simple words, if you just come across joint pains with the diarrhea, better think of ulcerative colitis, Crohn's disease, or just reactive arthritis. Also keep in mind if there's a patient with a darkening of skin and diarrhea, that's Addison's disease. But just as a pro tip, keep this thing in mind that Addison's disease is just not really common, so don't try to put it in the top of your differential list. Okay, so that was about father and son. Like father, like son. What about mommy? We give this mom a beautiful thyroid bow tie. And this purplish thyroid bow tie is going to represent thyrotoxicosis. So if there's a patient with a diarrhea, intolerance to heat, weight loss, increased appetite, and just prominent eyes or swelling in the neck, that's going to be hyperthyroidism. Okay, so one child is left. We're going to give him dry eyes and diabetes. Now, if there are painful red eyes that are seen in ulcerative colitis or Crohn's disease, or if you see the symptoms of polyuria, polydipsia, impotency that's seen in diabetic autonomic neuropathy. Woohoo! All of the family members are now diseased. Now that's satisfying. You see one child with rash, daddy with arthritis and Addison's, mommy with hyperthyroidism, and another child with painful red eyes and diabetes. That's a complete family now. What about the personal photographer? Let's give him diseases as well. We start by giving him vomiting. Now, if you see a patient with diarrhea and vomiting, that's viral gastroenteritis or Addison's disease or just IBD. One more thing you're going to learn about this photographer is he's wearing a flame bandana, which is going to tell you about fever. So if you just come across fever and diarrhea, that's because of viral gastroenteritis, bacillary dysentery, intestinal TB, or IBD. Or it could be just pseudomembranous colitis. In simple words, it's just infectious diarrhea. And to add more to the scene, we draw some wheat crops. Our advocate was shot dead and was thrown into these fields of crops. Now these crops are here to remind you of that wheat products can also cause diarrhea in celiac disease, or if they are just milk products, it is just lactase deficiency. Now that's actually a malabsorption syndrome, and you'll find weight loss and increased appetite, bone pains, pigmentation, pallor, and almost everything is wrong with the patient. Also, if you see a patient with a diarrhea, must ask about the weight loss. If there is weight loss with the increased appetite, that is because of hyperthyroidism or just malabsorption syndrome. If there is significant weight loss followed by diarrhea, can be carcinoma or tuberculosis or diabetes or hyperthyroidism or just malabsorption syndrome. If there's no weight loss and there's a long course diarrhea, it's just IBS or psychogenic diarrhea. Next we draw sun and moon. Now we're going to share the moon with that gorilla or Gohan or just ape or monkey, whatever he is, we're just going to share his moon. So the sun and moon are here to remind you of the diurnal variation. Ask your patient about it. If there's no variation, it's just infectious disease. If it's present in the morning after meal, that's because of gastric disorders or just psychogenic diarrhea it is. Also, morning diarrhea is seen in ulcerative colitis and Crohn's disease. And if there is nocturnal diarrhea, That is because of organic cause. And finally, before we wind up our second output terminal, don't forget to ask your patient about blood or fats or greasy, bulky, frothy stools. Now, this could be blood or malabsorption syndrome. So that was really about diarrhea. As a quick recap, now in this, you're going to ask your patient if there's blood, water, or bulky greasy stools that are hard to flush or just there is pus. Then ask about the pattern of diarrhea, which is just followed by other symptoms, for example, tenesmus, cramps, stress, itch, rash, weight loss, joint pains, red eyes, itch, or just diabetes, thyroid, Addison's disease. Ask about the family history. Ask about intolerance to milk or wheat products. Ask if there's blood or just fats in the stool. Also ask about fever and vomiting. Now let's really move to the final and third output terminal, and there's absolutely nothing. So if there's nothing, it means it's constipation. But wait. If you just focus in this terminal, you will find some of little blood. Either there's nothing, or if you find something, it's going to be blood. So if there's fresh blood in the stool, this is known as hematochezia, and it's seen in ulcerative colitis, Crohn's disease, hemorrhoids, or just colorectal carcinoma. Now, there are a lot of causes for the constipation, for example, lack of physical activity, low diet, nothing per oral. You really need to exclude that NPO. Besides these, the other causes include drug-induced constipation, for example, diuretics, antidepressants, aluminum-containing antacids, laxatives, some psychiatric problems, for example, anxiety and depression. They can give you constipation as well. IBS, systemic diseases, for example, diabetes, hypothyroidism, and pregnancy. And besides these all, there are other causes, for example, chronic amoebiasis, IBD, diverticulitis, or just the tumors of rectum and colon. So now it's really been a very long lecture on constipation. Let's move on to the associated symptom. First of all, we draw this beautiful baby panda here, and this cute baby panda is here to remind you of the physical activity. Just like pandas do nothing at all and they just eat and sleep all the time, so they have a poor physical activity. So if there's a patient with constipation, ask about physical inactivity, improper eating habits, poor bowel habits, inadequate fluid intake, and so and so. So this is really going to give you a clue about the constipation. Just as expected from a panda, always eating. So this panda is going to eat some sweet candies, not the bamboo this time, sure. Anyway, it's diabetes. So in the diabetes, you get polydipsia, polyuria, polyphagia, there's increased appetite. Also, there are some microvascular complications, for example, retinopathy, blurring of vision, nephropathy, you get the CKD, and neuropathy, in which you get tingling and numbness of the fingers, and also the autonomic neuropathy, in which you're going to get the diabetic diarrhea. Next up, I'm going to draw a beautiful pattern. It's going to tell you about the pattern of constipation and diarrhea. Just ask your patient if there's alteration of diarrhea with the constipation, and if it's so, it can be because of IBS, chronic amoebiasis, IBD, diverticulitis, or just laxative abuse. Next associated symptom is just pregnancy, and you want to keep it at the back of your mind. After the pregnancy, go for vomiting. If there's vomiting with the constipation, that is intestinal obstruction. And now here the question is, what are the other features of intestinal obstruction? That is vomiting, pain in abdomen, abdominal distension, and finally absolute constipation. Now we give this pregnant vomiting lady a beautiful thyroid bow tie. This thyroid bow tie is going to tell you about thyrotoxicosis. And along with pregnancy comes a lot of anxiety and depression. Or you can just say that anxiety and depression can also give you constipation. And finally, we're going to wind up this constipation with this chronic sign. Now, this chronic sign is going to tell you about the chronic diseases, for example, stroke, MI, diabetes, chronic amoebiasis. All these can give you constipation. So that was really all about constipation. And just to revise it, ask about the physical activity, diet, pattern, hematochezia, vomiting, thyrotoxicosis, diabetes, MI, stroke, chronic disease, anxiety, depression, or just pregnancy. So in the output terminals, we have talked about melena, diarrhea, and constipation. What about flatus? If there is inability to pass flatus, there's just abdominal distension. So we draw an air pump that is going to tell you about flatus, which is just besides this distended abdominal tent. Oh my god, that was really tough. I can't believe we're done with the GID and it's finally over. Just to revise this all, you're going to ask the patient about appetite, dysphagia, vomiting, hematemesis, jaundice, dyspepsia, edema, ascites, distended abdomen, and the stool details, which are going to include the diarrhea. It could be bloody diarrhea, it could be watery diarrhea, it could be with pus, or just malabsorption diarrhea. Then you're going to ask about melena, constipation, and flatus. So now let's move on to the genitourinary system, or you can just say nephrology section. Here we have a mnemonic, and that is find lime and hippo on a bloody polyuric fun ship. So what does that stand for? Well, glad you asked. F for fits, I for itch, and for nausea and vomiting. D for dyspnea. Lime stands for libido, impotence, metallic taste, and edema. Then we have hippo, which stands for hematuria, incontinency, pain in lumbar region, and just proteinuria. It's fine lime and hippo on bloody polyuric funship. Now, what is bloody? It stands for bleeding tendency. Polyuric, we have to ask about the polyuria. Now, what are the other extensive questions for the polyuria? It's funship. Now, this funship stands for frequency, urgency, nocturia, stream, hesitancy, intermittency, and post-void satisfaction. So these are the all complaints of genitourinary system. We're going to discuss this all in detail in our genitourinary section. So let's draw our scene. We have a large fun shape, and on that shape we have kids enjoying with the lime, and beside that we got a hippo. Okay, so now what? Is that all? Well, wait for a second. There's always more to show up. To tell you about fits, we're going to draw this epileptic man who is just having seizures underneath the ship or fun ship or something. I don't know. Anyway, we're having a man who is just having an attack of seizures. And to talk about seizures, we can always have a long duration since childhood or a recent onset. If it's from childhood, it's idiopathic epilepsy. And if it starts after the age of 30, that's because of symptomatic epilepsy. It can be because of space-occupying lesion, for example, tumor, abscess, hematoma, etc. Then you're going to ask about the frequency of fits. How many episodes do they get in one day? Now, the fits of the genitourinary system are somewhat different from the fits of the CNS system. Now, in CNS, you get a long list of seizures. They could be focal seizures. They could be with or without impairment of consciousness. Could be generalized seizures, including absence seizures, tonic-clonic seizures, tonic, atonic, myoclonic, or just epileptic spasm. However, the seizures of genitourinary system are somewhat different. They are because of uremia. So here we're just going to learn about the associated symptoms, and we're going to discuss these seizures in detail in CNS section. First things first, as I said earlier, ask about the duration and onset. So this board from morning to evening is going to tell you about duration and onset. Next, what is that? It looks like CD or compact disc or DVD to me. Maybe some DVD in which he has stored some of his memories. So this DVD is going to tell you about the memory for the fits. Now, if a patient has fits, ask about the memory for the fits. If there's no memory for the fit and the patient himself is not able to describe the fits, that is because of organic fits due to epilepsy. However, if the patient remembers everything about the fits, it's just hysterical fits. Then we draw some rash on our epileptic man. The rash on the face with the fits is going to tell you about Sturge-Weber syndrome or just tuberous sclerosis. Now we draw the disabled friends of this epileptic man who are just on wheelchairs, who have come along with him to enjoy this funship show. One thing you're surely going to notice is that the friend on the left side is actually paralyzed. He can't move his hands or feet, while the friend on the right wheelchair is absolutely fine. Actually, it's not friend, it's girlfriend. Anyway, you're going to see a lot of frogs or toads or whatever these are. I'm just calling them toads. You're going to see a lot of toads beside the paralyzed man in the wheelchair, and these toads are there to remind you of Todd's paralysis. So, a patient with epilepsy must ask about transient paralysis or just Todd's paralysis, and this could be because of temporal lobe epilepsy, which is related to CNS cause. Next up, the girl on the wheelchair. She is with the flame bandana, all time fully active, all ready to give headache to the other boy. So to give headache to the other boy, we're just giving him a headache cap. A girl with a flame bandana, highly active, and a boy with a headache cap, Sick of this girl's girlish talk. So sick that he eventually got paralyzed. This girl has not only given him headache, but she's also giving him anxiety and depression. That's what girls are for. Women. Anyway, just as refresher, when you're dealing with fits, ask about time, memory, fever, headache, paralysis, or just thoughts paralysis, anxiety, or rash. Next, we draw another next complaint, and that is itch. Now, this itch is actually a topic for the dermatology section, but just keep in mind that a patient with a chronic renal disease can also present with a severe itch. And that's actually a very common presentation of CKD. Okay, so next up, we're going to ask about nausea and vomiting. So we're going to represent this by a kid in the fun ship who is just nauseating. To learn more about nausea, you can always go to our GI section where our advocate Jamal Pandu was shot dead beside stool. By whom? By a weird machine. And if you just look at the second terminal of that machine, you're going to find a lot of causes of the vomiting. Next, what we have here in the fun ship zone is a pod. And this part is going to tell you about PND, orthopnea, and dyspnea. Now, this is also related with CKD. In the CKD, you get fluid accumulation in nephrotic syndrome, you get fluid overload in your body, and you can present with shortness of breath. To learn more about dyspnea, you can always go to our combined cardiology and respiratory section. The very same section where the prince of all sins got his arse beaten by a low-class warrior. Yes, sure. So that's enough talk about fits, itch, nausea, vomiting, and dyspnea. Let's talk about Lyme. Lyme stands for libido, impotence, metallic taste, and edema. So first, if we talk about libido and impotence, we draw a kid here who is playing with a sword. What? No, I don't think it's a sword. I think it's a weapon. And this weapon is not meant for kids because kids cannot have this weapon. Or if they have, it's just useless, like libido. Hey, listen, kid, you can't use this weapon right now. You're too young. This won't get straight. All you have to do is wait for your adolescence, really. So, okay, back to the lecture. So there's loss of libido sword or something like that, or we can say floppy sword, is going to represent the loss of libido and impotence. Now, the libido is really lost to DCLD, diabetes, thyroid diseases, anxiety, depression, and through certain drugs, for example, spironolactones. And just to help you remind all these causes, we're going to draw the cirrhotic liver tree along with both the thyroid diseases and a sugar candy jar and some drugs. And you know what? This kid is trying very hard to straighten this floppy sword, and this is going to give him anxiety or depression. Bro, you're too young to take anxiety and depression for this. All you have to do is wait for the right time, and things are going to straight up on their own, just like this sword. Okay, so let's continue our lecture and ignore that kid. What about the metallic taste? Yes, it's very common in the patient with chronic renal failure. So for this, we're going to draw these falling metal nails. All you have to do is ask the patient if they feel some metallic taste in their mouth. If they say yes, that's the patient of chronic renal failure. Looks like this huge fun ship swing is going to get down soon. You're all going to die, kids. Okay, so another complaint about the genitourinary system is edema. So we share some of the water from this edimator's water tank into our own fun ship scene. And to learn more about edema, head over to our cardiology section to learn more in detail about this edimator's edema water tank. Now that really sums up Lyme, which is libido, impotence, metallic taste, and edema. Now let's move on to hippo, shall we? Look who's standing beside this hippo. It's a girl, and she's having some pain in lumbar region. Now there are different causes for the pain in lumbar region. It could be because of ureteric colic due to obstruction by a stone, crystal, or clot. Could be UTI, could be glomerulonephritis, or just enlarged kidneys. As seen in hydronephrosis, polycystic kidney disease, or just the tumors of kidney. So when a patient complains of pain in lumbar region, all you have to do is ask for onset, duration, intensity, progression, associated factors, relieving factors, aggravating factors, character, radiation, periodicity, and a lot of these details. If the pain is unilateral, that's because of colic or hydronephrosis or tumor. If it's bilateral, it's most likely going to be polycystic kidney disease or UTIs or just glomerulonephritis. If the pain is colicky, that is because of ureteric colic. If it's dull, it's UTI or hydronephrosis or polycystic kidney disease. It can also be acute glomerulonephritis. Then ask about the severity of the pain, radiation. Now, if it's radiate towards the groin region, that's colic. Or if it's localized to the lumbar region, that's seen in all other conditions except colic. Now, if we talk about the associated symptoms of pain in lumbar region, first of all, we get this arthritis or joint pain and swelling. Now, if there's pain in lumbar region along with joint pain and swelling, that could be because of gout or just Neisseria gonorrhoeae. Next, we're going to draw S, which is going to represent mass. Mass, mass. Anyway, this donkey is with fever. So if there's a mass with a pain in lumbar region, that's because of hydronephrosis, polycystic kidney disease, or just renal tumors. And if there's fever with the pain in lumbar region, that is because of pyelonephritis or renal TB. Behind this mass is a kid who is urinating lava, a burning flamey urine. What? Now this is really giving me chills back in my spine. Ooh, painful. Anyway, so this boy with flamey urine is going to represent dysuria. So if there is dysuria along with pain in lumbar region, that is because of UTIs. Now we're going to draw many kids who are just urinating around. Now these are many kids, or you can say poly kids, and they are doing what? Polyuria. Yes, these many kids are going to represent the polyuria, and we'll come back to this polyuria again right after we discuss hematuria. And guess what? What else can be a good place to describe a hematuria besides hippo? So the girl sitting on the hippo just peed there and there's blood everywhere. Now the blood in urine is just called hematuria. Now we're done with the pain in lumbar region. To summarize, we can always ask dysuria, polyuria, fever, hematuria, joint pain, or just mass in the lumbar region. Now let's talk about hematuria. It's just the blood in the urine. Now, hematuria can be gross or microscopic, but only gross hematuria can be diagnosed with the history. Just as a pro tip, remember not every red urine is hematuria. It can also be hemoglobinuria, myoglobinuria, porphyria, or some drugs, for example, rifampicin. Now, the hematuria has a lot of causes, for example, renal diseases, renal stones, pyelonephritis, IgA nephropathy, also known as Burgess disease, tuberculosis, or in the diseases of bladder, for example, cystitis, calculus infection in bladder, or just vesicle tumors, urethritis, prostatitis, or just bleeding diathesis, for example, thrombocytopenic purpura, or just anticoagulation therapy. Now you'll ask about the duration of hematuria. If it's short, it could be cystitis, pyelonephritis, renal or vesicle tumors, or just renal trauma and infarction. If the duration is long, it is because of renal calculi, or just calculi in the bladder, or just benign recurrent hematuria. If the onset is sudden, it's just renal or bladder tumors or renal trauma. If it's gradual, it could be cystitis or pyelonephritis. If it comes in attacks, that's because of renal calculi or the stone in bladder or just IgA nephropathy. One very important question to ask is the pain. Is it painful or painless? If it's painless, that's because of tumors, polycystic kidney disease, or just bleeding disorders or benign recurrent hematuria. If it's painful, that is because cystitis, pyelonephritis, renal stones, or stones in bladder, or urethritis, prostatitis, or just renal infarction. Another important aspect is to ask about timing. If the hematuria is the beginning of micturition, this is urethritis. If it's at the end of micturition, this is cystitis or prostatitis. If it's uniformly throughout the micturition, that's seen in all renal diseases and bleeding disorders. And finally, if it gets bad with dehydration, that's because of renal stones or stones in bladder or just UTI. And if it gets bad with exercise, this is IgA nephropathy. Now, if we really talk about the associated symptoms, first of all, we get a discharge, and this is called urethral discharge. Now, if there's discharge and hematuria, that's because of gonococcal or non-gonococcal urethritis. So to tell you about this discharge, we draw this sticky discharge underneath that hippo. Next, you'll notice some red particles that suspiciously look like RBCs. So you're going to ask about the symptoms of anemia. So in a patient with hematuria, ask about the symptoms of anemia, for example, pallor, palpitation, fatigability, myalgias, breathlessness, dizziness, palpitations, and so and so. And besides this discharge, bleed, and anemia, other features which are associated with hematuria are fever, pain in lumbar region, mass, and dysuria. And we're really not going to draw this whole, we're just going to share these features. For example, we're going to share this donkey with the flame bandana, the girl with the pain in lumbar region, and the flamey boy with the flamey urine representing dysuria. We'll just share it with the hippo. Now, if there's fever with the hematuria, that's because of pyelonephritis, renal TB, or because of renal tumor. If there's dysuria with the hematuria, that's because of cystitis or just stone in kidney or stone in bladder or urethritis or prostatitis. If there's hematuria along with pain in lumbar region, that's because of stone in kidney or bladder. And finally, we almost forgot about that S. If there's a mass in the lumbar region along with hematuria and that mass is unilateral, that's because of renal tumor. Or if this mass is bilateral, that's because of polycystic kidney disease. Now that was all about hematuria. Just as a recap, in a patient with hematuria, ask about fever, dysuria, discharge, pain, mass in lumbar region, bleeding disorders, bleeding complaints, and anemia. Now let's move over to incontinency. We have another kid who just peed without any reason. Now that's the actual incontinency. Now this incontinency is seen in many diseases. For example, in the later stage of diabetes, we get this incontinency in prostate diseases and also in the sphincteral problems. And if there's injury to the spinal segment, we get incontinence. So ask your patient about incontinency. Also, you're going to ask your patient about froth in their urine. This is going to tell you about proteinuria. And there are many diseases in which you get the proteinuria. For example, nephrotic syndrome, you get proteinuria in the initial stages of CKD, diabetic nephropathy, and so and so. Next, let's go back to our many kids who are just representing this polyuria. Now, if a patient complains of polyuria, you might want to keep many causes under your differentials. And guess what? All these causes are explained by this Psycho's polyuric store. As the name shows, one of the causes for polyuria is psychogenic. It means the patient is just drinking enough water. So to differentiate between psychogenic polydipsia and pathological polydipsia, you're going to ask the patient about nocturia. If they have to wake up at night and go for urination, that's because of pathological. And if they do not wake up at night for urination, that's physiological or psychological polydipsia. Next up, you're going to see a jar of sweet candies. That's going to represent diabetes mellitus. In diabetes, you get the polyuria along with polyphagia and polydipsia. Next, what else is on this Psycho's polyuric store? Well, these are binoculars or just glasses used by spies. So these are spy binoculars, which are technically going to remind you of diabetes insipidus. Spy binoculars for diabetes insipidus. Now, along with polyuria, they're also going to have headache or just visual disturbances. Now, let's see what else can we find on this store. Well, here is a shake with a loopy straw. This straw is in loops. Oh yes, I know. This straw is going to remind you of loop diuretics. So it's very important to review the drug history of a patient with a polyuria. Are they patient of congestive cardiac failure or liver cirrhosis or nephrotic syndrome for which they are taking diuretics? You know, the store is also selling the Calci Yum ice cream. So let's add the banner of Calci Yum to remind you of that. The hypercalcemia is also a cause of polyuria. Now, in a patient with hypercalcemia, they're going to complain polyuria along with anorexia, nausea, vomiting, constipation, and bone pains. Next up, we're going to add this injured hanging kidney. That is going to remind you of chronic renal failure. Now, if a patient of chronic renal failure comes with polyuria, you're going to ask about anorexia, nausea, vomiting, diarrhea, metallic taste in the mouth, hiccups, pallor, or breathlessness. These are all the signs of chronic renal failure. One more thing you're going to notice from these polyuric kids is that one kid is too anxious. I don't know why, but he's anxious because other kids are making fun of that thing. Yeah, that thing. Anyway, we draw a sign of anxiety. Now, if there's anxiety and there's history of palpitation and then polyuria after the palpitation, that is paroxysmal atrial tachy. And finally, to explore this polyuria in more detail, we have this funship, or simply we have this bloody polyuric funship. Now, if we just skip bloody for a moment and focus on the word funship, we're going to see its frequency, urgency, nocturia, stream, hesitancy, intermittency, and post-void satisfaction. You're going to ask your patient how many times do they have to go. This is frequency. This is increased in many diseases as seen in the polyuria. Next, you're going to ask about the urgency. This is going to tell you about incontinency. Then you're going to ask about nocturia to separate the psychogenic polydipsia from the pathological one. Then you're going to ask about the stream. The stream is disturbed in a lot of cases. For example, prostatitis. The stream is disturbed in stricture. It's also disturbed in other surgical causes. And of course, stream is also disturbed in renal stones. Then you're going to ask about hesitancy. Can they easily initiate urination? Then you're going to ask about intermittency. Now, this is seen in prostatitis. And then finally, you're going to ask about post-void satisfaction. Are they satisfied after peeing, or they feel the urge to pee again for the second time? So this funship mnemonic is basically for the BPH, which is benign prostatic hyperplasia. And now let's go back to the bloody part of bloody polyuric funship. Yes, bloody. This bloody stands for bleeding tendency. And to represent this, we're going to draw some pipes, and one of these pipes is red. It means bloody pipe. As you can see, a lot of blood is coming out of these pipes, and this is going to represent the bleeding tendency. One thing that you're going to notice is that there are some red particles that are suspiciously looking like red blood cells, and they're here to tell you of anemia. So in the bleeding disorders, ask about anemia. Now, if we talk about the bleeding disorders, we can have disorders of coagulation, platelets, we can have disorders of both coagulation and bleeding disorders, and vascular defects. Now, this bleeding disorder is seen in chronic kidney disease where the hyperuricemia doesn't allow the platelets to fuse. So if you see a patient with a bleeding disorder, ask about the age of onset. If it starts from childhood, that's because of hemophilia, thrombocytopenia, Henoch-Schönlein purpura, or von Willebrand disease. If it's in adults, that's because of aplastic anemia or autoimmune thrombocytopenic purpura, hereditary hemorrhagic telangiectasia or DIC. If it's in old age, that's the senile purpura. Ask your patient about the site of bleeding. If it bleeds in muscles, joints, and deep tissues, that's because of hemophilia or Christmas disease or just an anticoagulation therapy. If it bleeds superficially, for example, epistaxis, bleeding from gums or mucous membrane or skins or petechiae, that's because of thrombocytic purpura, acute leukemia, von Willebrand disease, thrombasthenia, or just hereditary hemorrhagic telangiectasia. Next, you're going to ask about the type of bleeding. If it's sudden and stops within 48 hours, that's because of thrombotic purpura, von Willebrand disease, or DIC. If it's gradual and does not stop easily, that's because of hemophilia or Christmas disease or anticoagulant therapy. Now, after site and type of bleeding, ask about character of the bleeding. If it's pinpoint, it's petechiae. If it's on buttocks and legs of a children, that's Henoch-Schönlein purpura. If there are bruises, it's senile purpura. Or you can also have Cushing's under differential. If there's subcutaneous hematoma, that's because of hemophilia or von Willebrand disease. Now let's move on to other associated features with the bleeding tendency. Ask for lymphadenopathy. If there's bleeding tendency along with lymphadenopathy, this is going to be acute or chronic lymphocytic leukemia. What else can you ask your patient? Well, you can always ask about fever. If there's fever and bleeding tendency, this can be aplastic anemia or acute leukemia. Next, we're going to add a pole among these pipes. And on that pole is a red handkerchief hanging around. And this red handkerchief is the recurrent sign for the sore throat. If there's sore throat along with bleeding tendency, that's going to be aplastic anemia. And just before winding up things, if there's joint pain, oliguria, hematuria, and abdominal pain with bleeding tendency, that's Henoch-Schönlein purpura. And just to summarize the associated features of bleeding tendency, you can always ask about sore throat, fever, lymphadenopathy, joint pains, oliguria, hematuria, abdominal pain, or anemia. And one more thing before we go, just keep DIC in mind. So to remind you of that, we'll draw this big dice. So just make sure you rule out all the causes of DIC, for example, snake bite, infection, or carcinoma, etc., etc. Now that really concludes our section of history taking about genitourinary symptoms. How about we give it a recap? What do you say? First of all, you're going to ask about fits, itch, nausea, vomiting, and dyspnea. Then you're going to ask about libido, impotence, metallic taste, and edema. Then you're going to ask about hematuria, incontinency, pain, and proteinuria. Then you're going to ask about polyuria, and associated features, along with extended features of polyuria, which is just funship, frequency, urgency, nocturia, stream, hesitancy, intermittency, and post-void satisfaction. Then you're going to ask about the bleeding disorders. Phew, that's it. That was pretty simple. Okay, so next we move to the CNS system, or you can just say the neurology section. Now, what we really have for here is just 10 very piercing and bad fights per week in a damp season. Yes, that's it. That's the scene for the CNS. 10. T stands for tingling and numbness. V stands for vertigo and vomiting. Piercing. F stands for fasciculation. So right now you get the tingling, numbness, fasciculation, vomiting, and vertigo. Then we get bad. B stands for blindness, A stands for aphasia, and D stands for diplopia. Next up, we have fights per week in damp season. Fight stands for fits, G stands for gait, H stands for headache, T stands for tremor, and S stands for stiffness in neck. Next, we have per week, which stands for paralysis and weakness, and then damp, which is depression, anxiety, memory loss, and palpitations. And season stands for syncope. So tingling, fasciculation, numbness, vomiting, vertigo, blindness, aphasia, diplopia, fits, gait, headache, tremors, stiffness in neck, paralysis, weakness, depression, anxiety, memory loss, palpitation, and syncope. These are the really complaints related to CNS. Now let's dive into the CNS scenario by drawing a stage where everyone is just fighting. And you know what? It's a very piercing and bad fight. In this fight, you'll see everyone. Bodybuilders, from The Undertaker to the Triple H. Also, you're going to see boxers, babies, monkeys. What? Babies and monkeys as well? Sure, you're going to see them all. After all, it's very piercing and bad fight. So we draw a stage here, and on that stage, we draw two wrestlers who are just fighting for their lives. You know the wrestler with the red pants? Oh yes, he's Shock Michaels. Now why Shock Michaels? That's because he appreciates feeling of shocks, like tingling and numbness in his legs. That's why we have drawn his red pants along with shock symbols. Oh man, Shock Michaels is really punishing him hard. So hard that even the boundaries of the stage are flicking, just like fasciculation. So numbness, tingling, and fasciculation, we have covered all three symptoms. Now, if the patient tells you about the fasciculation, better think of motor neuron diseases. And if the patient tells you about numbness and tinglings, go for neuropathies. Next up, here comes 175 pounds, Hemi Mysterio. And you know he flies like a butterfly and stings like a bee. One thing you're going to notice is the half of the body is red. That's why he's called Hemi Mysterio. This means he's actually flying with the half of the body not even working. This is hemiparesis, and this hemiparesis falls under the category of paralysis and weakness. So let's discuss paralysis and weakness in a little bit detail. Now, if a patient presents with the muscular weakness, it has a lot of causes. For example, upper motor neuron lesions, lower motor neuron lesions, combined upper and lower motor neuron lesions, peripheral nerves disease, or just neuromuscular junction disease, or just the diseases of the muscles. Now, if we talk about the diseases of upper motor neuron lesions, we got stroke, transphospholitis, primary lateral sclerosis, and progressive pseudobulbar palsy. While the diseases of lower motor neuron include poliomyelitis, progressive muscular atrophy, progressive bulbar palsy. And if you try to find the causes of combined upper and lower motor neuron lesions, you get ALS, cervical myelopathy, and syringomyelia. If we talk about the diseases of peripheral nerves, we get diabetes, Guillain-Barré syndrome, Friedreich's ataxia, peroneal muscular atrophy, or some alcoholic neuropathy, folic acid, vitamin B12 or B6 deficiency. Now, all these fall under the category of peripheral nerve disease. If we talk about the neuromuscular junction diseases, we get myasthenia gravis. And if we talk about the diseases of muscles, we get muscular dystrophy, hyperthyroidism, hypothyroidism, Cushing syndrome, and familial periodic paralysis. Also, you're going to count polymyositis and dermatomyositis as the disease of muscles. Now, when you're ready to take the history, you'll ask about the onset. If it's with few minutes, this is stroke. If it's taking few hours, this is poliomyelitis or transphospholitis or GBS or stroke due to thrombosis. If it's taking weeks or months, that is actually motor neuron disease, muscular dystrophy, familial periodic paralysis, or acute thyrotoxicosis. After asking the onset, you're going to ask the type of disability. For example, you're going to ask if they can easily go upstairs or stand. And to remind you of that, we have drawn these stairs beside the show. Now, if the patient cannot stand or go upstairs, that's because of the weakness of proximal muscles of the lower limb. If the patient cannot go downstairs or cannot sit, that's the weakness of distal muscles of the lower limb. Now, if the patient cannot comb their hair, that's the weakness of proximal muscles of the upper limb. And if the patient cannot write or hold something, that's the weakness of distal muscles of upper limb. As a rule of thumb, proximal muscles are usually involved first in the myopathies. Now that's enough talk about the muscular weakness. Now you're going to determine the pattern of weakness. If it involves one half of the body, just like we're seeing in hemimestereo, that's stroke. Now the weakness can also involve one muscle or a group of muscle, and this is neuropathy. We show this by drawing one muscle of the hemimestereo with the red color. Next up, as you see, when the shock Michael hits his opponent, he cannot move his arms, and his arms are just freezed. We're showing this by coloring his arms with a red color. Now, if there is weakness of both arms, this is going to present as facial scapulohumeral muscular dystrophy, or ALS, or GBS. Wait a minute. It's not only the arms, it's also the hip girdle muscles. So when the patient complains of the weakness of hip girdle muscles, better think of poliomyositis, dermatomyositis, progressive muscular dystrophy, or just metabolic or hormonal disorders which are actually leading into myopathies. Next up, we're going to draw the CEO of this 10-fight stage. Here comes Nick Khan, and you know what's wrong with him? He cannot walk properly. There's something wrong in his gait. So you're going to ask about the gait of the patient. Has it changed recently or not? Well, there are different types of gaits. For example, penguin gaits, you can have circumduction gaits, and so on and so. But we're really not going to discuss those all gaits because they don't fall under the category of history taking. Right now, we're just focusing to diagnose the disease on the basis of history. So long story short, just ask them if there's a change in the gait or they can walk properly. Next, you're going to see the CEO wears these bangles, one on wrist and one on ankle. And these bangles are going to tell you about the wrist drop or the foot drop. Now, the distal limb weakness, for example, foot or wrist drop, is seen in familial peroneal muscular dystrophy. Now, let's draw another wrestler with a cast on his leg. Now, this is going to represent the clubbing of foot, and we'll come back to you later. Just hang in there, baby, and keep screaming. Now, I wonder what kind of wrestling is that without any commentary on it. So let's add a desk for the commentators behind the stage. So as you can see, we have added 3 different folks, and there is a mic in front of them, and that mic is red. I mean, it's useless, it's not just working. So what does that mean? It means you cannot speak? Is this dysphonia or dysarthria? Who knows? I guess both. Also, we're going to add an apple, and guess what? It's again red. They cannot eat it. And if they cannot eat it, is this dysphagia? So in a nutshell, if there's a patient with dysarthria, dysphonia, and dysphagia, and he presents with the muscular weakness, it's good to think about bulbar palsy or just motor neuron diseases, bulbar poliomyelitis, and diphtheria. Next up, we have a third person with the weakness of eyes. So we represented his eyes with a red mask. So if you really come across a patient with the weakness of eye muscles and he is presenting with the complaints of double vision, drooping of upper eyelids, or squint, better think of lesions of the 3rd, 4th, or 6th nerve, or it could be myasthenia gravis, thyrotoxicosis, or myotonic dystrophy. And here's a plot twist. The desk of the commentators was built on the grave of a famous wrestler known as The Undertaker, and he was also known as the Dead Man. Now watch out, watch out, watch out! Who's this? This is The Undertaker. Oh my god, that's unbelievable. He has just popped his head out of the desk. Oh. And as you see a head, you're going to ask the patient if they can hold their head. Now, if there's weakness in holding the head, that could be because of polymyositis. Or if there's weakness in lifting the head from the pillow, that is because of the sternocleidomastoid muscles. For example, in progressive muscular dystrophy or motor neuron diseases and syringomyelia. So asking about holding the head is really important. Now let's go back to our young fellow who was constantly in pain with a cast on his leg. And that cast is going to represent club foot. So if there's a patient with a club foot or deformity, better think of the peroneal muscular atrophy, Friedreich's ataxia, or just hereditary spastic paraplegia. Now, as I mentioned earlier, this is a very, very bad and fearsome fight, and almost everyone is going to take part, including these young kids. So let's draw these green babies that are going to tell you about the pattern of weakness. It could be generalized, it could be ascending, could be slowly progressive, it could be chronic. Now if you take a moment and look at these babies, one of the babies is with the barbell. Now he is a chronic gym boy. So that baby with the barbell is going to represent the chronic paralysis. Now if you see the second baby on the stairs, he is just trying to move slowly. Now this is going to represent the slowly progressive pattern of weakness. If you see the third baby, that's trying to ascend onto the stage. So he's going to represent the ascending paralysis. And finally, we have a fourth baby that is already sitting on the top. This is going to tell you about acute and episodic paralysis. Now, the chronic paralysis is because of polymyositis and spinal muscular atrophies. Slowly progressive paralysis is because of the motor neuron diseases and muscular dystrophy. Ascending paralysis is because of the Guillain-Barré syndrome. And generalized paralysis that involves acute and episodic pattern, that's because of periodic paralysis or thyrotoxicosis. Now we draw a pair of these security cameras and one of the cameras is just down, and that is going to represent the drooping of the upper eyelid. And this is seen in myasthenia gravis and myotonic dystrophy. Next, where there are bad fearsing fight, there are always traumas associated with death and wasting. So here's a wasted person lying beside the stage. I know, he was caught up in a big blow. When you take parts in fearsing fights, that's very natural. So remember to ask about the wasting of the muscles. Then we're going to draw the diarrhea from this dead man, and just before the moment he expired, his red handkerchief from the neck just dropped onto the ground. So that means if there's a patient with a history of sore throats and GI symptoms and few days later it presents to you with a muscular weakness, you must think about transverse myelitis, Guillain-Barré syndrome, and poliomyelitis. Also ask about the history of rash that is seen in dermatomyositis and SLE. Next thing, you're going to ask about the fever. So we set this whole stage on fire to double the spice. Why fever? Well, good thing you asked. It carries the same significance as sore throat or GI symptoms in context of transverse myelitis, GBS, and poliomyelitis. One more thing, there must be pain and blood shedding in this fight. So we're going to add a big banner of pain. Yeah, more pain. Okay, so you're going to ask about the pain, and in this case, you're going to ask about the pain in muscles. That is seen in dermatomyositis or polymyositis and in early stages of neuropathies. After seeing this whole fight and pain and blood shedding, one of the persons around just lost his consciousness and started shaking like anything. That's the fits. So to tell you about fits, we draw this fits man from the genitourinary function playland. Do you remember that? The person with the fits and rash and memory loss and timing of fits, and its two friends, one with the fever, one with the headache and anxiety, one with the paralysis, and you're also going to ask about the Todd's paralysis. Well, that's it. Well, these are the associated symptoms that are common to both the CNS system and the GU system. In the GU system, there are fits from hyperuricemia. In the CNS system, there are fits other than hyperuricemia. So what you're going to do is ask the witness to tell you the description of fit. You're going to ask about a cry or fall to the ground or tongue bite or cyanosis, or just ask about the flinging movements of the limb, loss of bowel or bladder control. Ask the witness if the patient just slept after the attack of fits, or if the witness tells you about the brief absence, that's absent seizures, or if the witness tells you about the involuntary muscle contractions, that's myoclonic jerk, or if the witness tells you about sudden fall or loss of motor tone, that's because of the akinetic seizures. Ask the patient or the witness about auditory, olfactory, or gustatory hallucinations. These are seen in temporal lobe or psychomotor epilepsy. Ask about the Jacksonian seizures and try to rule out epilepsia partialis continua. Now, if there's a young tense female without any loss of consciousness and she presents with a deep sighing respiration and there are also irregular movements of the limbs, it's good to think about hysterical fits. And finally, ask about the precipitating factors, for example, anxiety, emotional outbursts, or just flickering lights. And that's it. We have covered fits completely. Next, we're going to talk about the headache, and for that, we're going to draw these two boxers. And to help you understand better, we're giving one of these wrestlers a headache cap. This headache cap is a recurring symbol for headache. Now, when you see a patient with headache, ask them since when. Ask them the site. If it's generalized, that's tension headache. If it's on one side, that's migraine. If it also involves one eye with lacrimation and rhinorrhea, this is going to be cluster hemorrhage. If first it's localized and then it spreads to the whole head, that's because of intracranial pressure. Now, if it's the worst headache of your life with the predominant occipital localization, this is subarachnoid hemorrhage. If it's just involved the occipital region with the neck stiffness, this is meningitis. Also remember, neck stiffness can also be seen in subarachnoid hemorrhage. If it involves the temporal side, this is temporal arteritis. Then you're going to ask about the corrector. If it's band-like, pressing, squeezing, this is tension headache. If it's throbbing, it's migraine. If it's dull, it's cluster hemorrhage or meningeal irritation with the eye and ear discharges. Ask about the severity of the headache and then followed by diurnal variation. If it's nocturnal, that's because of cluster headache. If it's early morning, that's migraine, hypertension, and intracranial pressure. If the headache starts getting worse in the morning, reaches maximum intensity at noon, and then subsides, this is frontal sinusitis. If there's no specific timing, this is tension headache or meningeal irritation, or just referred pain from eyes and ears. Next up, you're going to ask about the prodromal symptoms. For example, anorexia, nausea, lights, transient hemianopia, hemiparesis, or just speech disturbances. And all these prodromal symptoms are seen in migraine. There are some aggravating factors which are going to help you rule in or rule out different types of headaches. For example, bright light, tension, cheese, chocolate, these are going to aggravate migraine. Fatigue and anxiety, these are going to worsen the tension headache. Alcohol, this is going to worsen migraine and cluster hemorrhage. Coughing and straining, this is going to worsen the intracranial pressure, which is just causing headache. Now, if you're reading books and there's a lot of strain in your eyes, that's because of refractive errors of the eyes. If there's high blood pressure, this is headache because of hypertension. Noise and bright light can worsen meningeal irritation, as seen in subarachnoid hemorrhage and meningitis. And if the headache gets worsened when you lean forward, that is because of sinusitis. Now that's a long lecture on headache. Why not shall we talk about the associated symptoms? Oh yes, of course we will. So first of all, it's fever. The boxers are flamey. They're fighting in the flames. Now, if there's fever and headache, that is more likely because of meningitis or encephalitis. Next thing, you're going to ask about water from the postnasal side, water from nose, and water from ears, and water from eyes. Now, if there's watering in the postnasal side, that is just postnasal discharge, and this is seen in sinusitis. So the headache is because of sinusitis. While if you see water from the ear or tinnitus or deafness, that's seen in otitis media, mastoiditis, or temporal lobe abscess. Besides this all, if the patient says they have watery eyes and watery nose, now that's lacrimation and rhinorrhea, and that's seen in cluster hemorrhage. Next associated symptom, oh yes, there's a wrestler who drinks a lot of water and then splashes it everywhere thinking he looks cool. Presenting to you triple vomitus. But wait. I don't think it's water. I think it's vomitus. He's just splashing vomitus everywhere. Ew, gross. So this pressure vomitus is going to tell you about the projectile vomiting that is most likely seen in CNS causes. So if there's a patient with the projectile vomiting, drowsiness, confusion, and coma, and he presents to you with a headache, that's because of raised intracranial pressure due to space-occupying lesions or just meningeal irritation. To learn more about vomiting and its causes, head to my GI section and see the second input terminal of that weird machine. Next up, the triple vomitus is wearing neck protection. Now, this is here to remind you of neck stiffness. Now, this neck stiffness is usually seen in meningitis or subarachnoid hemorrhage, and in rare condition, it's seen in hypertension, refractive errors, or the space-occupying lesions of the posterior cranial fossa. Now, as you see these two boxers fighting so fiercely, one of the boxers punches the other so hard that his glasses just fell off from his face. Go red, go! Go red, go! Beat him! Knock him off! Well, these falling glasses are there to remind you of refractive errors of the eye. Ask the patient if they had their eyesight checked or they regularly wear their glasses. Next up, we draw this syncope windmill. And to learn more about this syncope windmill, head over to my CVS unit. Next up, we're going to draw a vertigo vortex behind the stage. Yes, a vortex that is going to represent vertigo. Now, vertigo is just revolving, and the patient is going to tell you, I'm spinning. Or if I'm not spinning, the world is spinning. Now, if we talk about the common causes of vertigo, we can have psychogenic vertigo. We can have vertigo because of acute labyrinthitis, Meniere's disease, or benign positional vertigo. Some tumors can cause vertigo, for example, acoustic neuroma. Otitis media can cause vertigo. Vertebrobasilar insufficiency, cervical spondylitis, and systemic diseases, for example, hypertension, anemia, high-grade fever, all these can cause vertigo. Now let's talk about the associated symptoms of the vertigo. Now this vertigo is brought along with a monkey out of nowhere? What is that? And now this monkey is really going to appreciate the spinning world around him. While this monkey spins, or the world around the monkey spins, he is just splashing vomitus everywhere. So if you see a patient who complains of the world spinning around him, along with vomiting and nausea, that's because of acute labyrinthitis or Meniere's disease. It's also seen in migraine. Oh, it looks like the vertigo brought this whole family of monkey along with it out of nowhere. Anyway, let's continue. Here we can see another monkey just sitting on the top of the paint banner and he is just plugging his ears. Is he having some kind of chronic pain or something? Now, I think it stands for the ear symptoms. Ask about the symptoms of ear disease. For example, deafness, tinnitus, or ear discharge. Now, that's really seen in otitis media, acute labyrinthitis, Meniere's disease, acoustic neuroma, and cerebellopontine tumors. Now, the face of the monkey just turned red. Is he scared of these fearsome fights? Who knows? This red face is going to tell you about the facial weakness. If there's facial weakness, paralysis, double vision, along with vertigo, that's because of vertebrobasilar insufficiency. Also, you're going to see this monkey is thinking about something, or he's just anxious, or just panicked to see all these fearsome fights. Well, who knows? All I know is this seems anxiety to me. Ask about symptoms of anxiety in a patient with the complaints of vertigo. If there is anxiety, ask about palpitation, numbness, fatigability, anorexia, insomnia, and failure to take a deep breath. If all these symptoms are positive in conjunction with the vertigo, that's hyperventilation or just psychogenic vertigo. Next, what we have here is a monkey who is just giving a very nice pose. I like your pose, man. And he's also wearing something in his neck. That is neck stiffness. So while taking history of vertigo, ask about the effects of posture. Now, if the vertigo is related to the position of head or body, this is just benign positional vertigo or cervical spondylosis. On the other hand, if you appreciate stiffness in neck, with or without pain in joints, that's because of cervical spondylosis. So in a nutshell, in cervical spondylosis, you can also have vertigo and there's effect of posture and stiffness in neck. Next, we draw two more monkeys that the vertigo vortex brought them with it. Now, the monkey at the back is just palpating the monkey at the front. So you're really going to ask about the attacks of palpitation. If there are attacks of palpitation and vertigo, that's because of the cardiac cause. And it could be because of cardiac arrhythmias. Now, another thing you're going to notice about the monkey at the back is he's wearing a headache cap. So ask about the history of headache. If the patient complains of headache along with vertigo, go for migraine, acoustic neuroma, or just cerebellopontine tumors. And finally, we have depression, anxiety, memory loss, and palpitation. You'll notice that we have already discussed these in conjunction with the other symptoms. For example, we have already discussed depression, anxiety, and memory loss along with fits, and palpitations along with the syncope windmill. So that's really going to end our discussion on CNS. What do you say? How about a quick recap? Well, as far as CNS and neurology are concerned, you're going to ask about paralysis and weakness associated with tingling, fasciculation, numbness, vomiting, vertigo, blindness, aphasia, or diplopia. Then you're going to ask about fits, gait, or just change in gait, headache, tremors, syncope, stiffness in neck, or depression, anxiety, memory loss, and palpitations. Okay, so now we move to the dermatological section and we have a new mnemonic, and that is rip and help. And that means rash, itch, patch, and that you're also going to take history about nails, hair, lump, and pigmentation. So now let's dive into the scene and make a typical presentation of help and rip. Yes. What else can be a good place to call for help besides this graveyard where you have the reaper or just the dead man standing beside you? Now, as you can see, there's someone calling for help through the grave while the reaper stands beside. Now, as a rule of thumb, first things first. So we're going to discuss itch first, and we're going to represent it by an itchy dog. Now, itching is also known as pruritus, and it has multiple causes. Sometimes this itching is with visible skin lesions, while the other times this itching is without visible skin lesions. And in that case, you're going to say that itch is secondary to some systemic disease. And third, we can have psychosomatic causes. First of all, we're going to talk about the itch with a visible skin lesion. So in this type, it's going to include allergic conditions, for example, urticaria, contact dermatitis, or just insect bite. Now we'll draw a wheel beside this itchy dog. This wheel is going to tell you about wheals, which can be with or without puffiness of lips or eyelids. And these wheals are seen in urticaria. Next, we'll draw some green glowing light that suspiciously looks like antibodies. Oh yes, of course, it's an antibody. And these antibodies are seen in allergic reaction, for example, contact dermatitis, insect bites, and urticaria. So if there comes a patient with itching, must rule out these allergic conditions. Now what's more next, we draw two bears, and one of the bear is polar bear, and the other is just a standard bear. Now the polar bear belongs to a very cold environment and the standard bear belongs to a very hot environment. So you're going to ask about the frostbite or prickly heat sunburn. Also, you're going to notice that there are a lot of mosquitoes around, so you must exclude malaria as well, as malaria can also cause itching. Onto the frontmost grave, you can see a large Sarcoptes scabiei. This bug is here to remind you of scabies. And to the left side of this big grave, you're going to see a lot of mushrooms. Well, these mushrooms are actually fungi, and they are here to tell you about the fungal infection. Now, these fungal infections include Tinea capitis, Tinea favosa, Tinea corporis, Tinea cruris, Tinea unguineum, Tinea barbari, Tinea manum, Tinea pedis, Tinea imbricate, Tinea fasciae, and Tinea gladiatorum. Must keep all these fungi in the back of your mind. Whoa, 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 what else do we have here? We have here is a pangolin. Now this pangolin is a very scaly animal. It's full of scales and it's going to represent these scaling skin diseases. For example, seborrheic dermatitis, atopic eczema, lichen planus, and ichthyosis. In addition to that, if you concentrate on the graveyard, concentrate with the really focus, you're going to see one of the graves is just glowing red. What do you think it could be? Well, I think it's some sort of infection or inflammation or something like that. Well, it's folliculitis. So if there is a patient with itch and visible skin lesion, must keep folliculitis, eczema, and fungal infections in the back of your mind. Now, these all were the causes of itch with a visible skin lesion. And just to remind that includes allergic reaction, for example, urticaria, contact dermatitis, insect bite, and it also includes frostbite, prickly heat, sunburn, malaria, and scabies, pinworms, folliculitis, eczemas, fungal infections, and scaling skin diseases. Now let's move to the other side where there's itch without any visible skin rash. I mean to say there's an itch that is secondary to systemic diseases. So in that scenario comes first of all the senile pruritus, also known as steatosis. And we're going to represent this senile pruritus by this old man who has just come to visit her, late gone wife. Next, we're going to give this old man a thyroid bow that is going to tell you about hypothyroidism. And in the hypothyroidism, you also get itch. Now, this old man is sitting under a tree that suspiciously looks like the biliary tree. So must look for the biliary obstruction because biliary obstruction can also lead to itch. Well, in all cases where you suspect obstructive jaundice, must ask about jaundice and clay colored stools, and this can really give you a clue about the region of the itch. Also, we get itch in the chronic renal failure, which is represented by this injured kidney. And to be honest, pruritus can also be the presenting complaint of a patient suffering from CKD. So if you think that itching is because of renal failure, must ask about pallor, breathlessness, metallic taste, nausea, vomiting, oliguria or polyuria, or just head over to our GU section. Then we're going to draw a jar of candies that's going to represent diabetes. In the diabetes, we can also have itch, tingling and numbness and burning in hands and feet. If you suspect so, ask about polyuria, polydipsia, change in vision, previous history of MI or CVA or peripheral arterial disease, or just ask about the neuropathy symptoms, nephropathy symptoms, or retinopathy symptoms. This is surely going to support your diagnosis as diabetes mellitus. Next, if you just look at one of those graves very carefully, very carefully, you're going to see that there's strange pattern on the grave, just like 4 dots. And you know what? To your surprise, these 4 dots just resemble the parathyroid gland. So in hyperparathyroidism, you also get the itch. What else can we find in this graveyard? Well, we can always find a lot of pinworms and hookworms. These worms are going to tell you about intestinal parasites, and these intestinal parasites can also give you itch. Or if there are no parasites but you still get the delusion of parasites under the skin, that's parasitophobia. And this is sufficient to give you itch. Now, if you look at the Reaper, you're going to learn that he's fond of collecting different keychains. One of the keychains is just like crab. The second keychain is a smiley face, and the third keychain is an archer. So these keychains are there to remind you of malignancy, a cancer sign for malignancy, a smiley face for carcinoid syndrome, and an archer for lymphoma, for example, Hodgkin's lymphoma. So in all these diseases, you're going to get itch, but without skin lesion. Now, if we add more detailing to the Reaper, we'll come to know that he is wearing a beautiful necklace. Bro, that's for girls, okay? So ask your patient about lymphadenopathy, and that's seen in Hodgkin disease and other lymphomas, and it's strongly associated with itch. Next, we draw a scarecrow with jaundice. I bet if you're a keen observer, you'll find that this jaundiced scarecrow just lacks the elastic bandages on his chest. So it means it's only jaundiced without any chest pain. So if your patient gives history of jaundice with clay-colored stools, well, in that case, the itch is because of obstructive jaundice. Next, we see, whoa, there are rubies everywhere. It's raining, and these are rubies. Is this magical graveyard or something? What kind of sorcery is this? I don't know, but if you know, just let me know as well. Anyway, back to our lecture, and these rubies are there to tell you about polycythemia rubra vera, in which there's an itching after taking hot baths. We draw a pod. It's the same pod from the Prince of All Saints. It's back. He has come again for more. So when you see a pod, just forget about Vegeta and start thinking about PND, orthopnea, and dyspnea. In simple words, pod stands for dyspnea. So now just imagine there's a patient who complains of attacks of sneezing, watery discharge from the nose, and that is with breathlessness, wheeze, and itch, and this is going to be atopic asthma. To learn more about POD, follow our cardiology and respiratory combined system. Now this really completes all the causes of itching that are secondary to systemic disease, and this is itch without a visible skin rash. Now just as a refresher, they all include senile pruritus, biliary obstruction, chronic renal failure, hypothyroidism, diabetes mellitus, hyperparathyroidism, malignancies, for example, Hodgkin's lymphoma, carcinoid syndrome, and intestinal parasites, for example, pinworm, hookworm, drug reactions, polycythemia rubra vera, and bronchial asthma. Next up, you're going to talk about nails, and the nails get deformed or tightened in scleroderma or Raynaud's phenomena. But that's really a clinical diagnosis. Right now, we're just focusing on the history. And what about the clinical examination? Well, that's a topic for another day. Then we give this Reaper some hair. Oh my god, she has been the girl all the time? And I was thinking her to be a boy all the time? Oh my god. Give me a break. Well, now that you have seen her hair, just keep in mind that you're also going to take the history about hair, hair loss, hair fall, baldness, and so on so. After that, now to turn this graveyard into something more creepy, we just draw some lumpy pumpkins around. And these pumpkins are going to tell you about lump. So you're also going to ask about lump. Now, there are just some stupid questions about lump, like how did you notice it first time? What were you doing first time? How did you come to know about that? And just like these random questions, are there many other lumps as well? Now, then you're going to ask if it's painful or painless. Then you're going to assess the features of the tissues around the lump and so on and so on. Well, the examination of lump really belongs to the category of surgery. It's not just a topic for the medicine. And finally, you're going to ask about some pigs, pigmentations. So these pigs are there to remind you of pigmentation. And to add more detail to this Reaper, we just come to know that her raincoat was torn. And so we stitched it up for her. Now what we really did was patching. We just patched her raincoat. So you must ask about any patch on the skin. And finally, to sum up this whole discussion, we give this Reaper a rash. Must ask about the rash. And now this really concludes our discussion on the dermatology section. So just to revise all these symptoms, we're going to ask the patient about rash, itch, patch, nails, hair, lump, and pigmentation. And woohoo! Our dermatology is done. And now it's time to move into rheumatology section where we got two doctors, Dr. P and Dr. PH, also known as Dr. Peter and Dr. Peter Henderson. And I don't know why Dr. P punches Dr. PH. Bam! So that's really the mnemonic for today, and that is dry eyes, rash, photosensitivity, hair loss, and dry mouth. Then we're going to see about the Raynaud's phenomena, psoriasis, back pain, arthralgia, arthritis, and then myalgia. And that's really going to cover whole of the rheumatology. So let's dive into the scene. Now, as I said, Dr. P punches Dr. PH. Bam! And that's our scene. Now, to add more to the scene, we add some more doctors and they are just going for the tug of war. Now, just like you can see, they are absolutely unequally divided. Are you really sure you're going to take them all out? That's really a one-man army. And I think that's the reason our Dr. P punched our Dr. PH. That's an absolutely cheating. Before we start, wait. How are you going to start if you don't even make the creases? What kind of game is that without marking and creases? So let's chalk out some creases onto the ground to tell you about the starting and the ending points. Now, if you really try to focus on this tug of war, you're going to find that we have only one doctor on the left side. Now, this one doctor is going to represent the involvement of only one joint, which is just monoarticular joint. While on the right hand side, you're going to see many doctors pulling the rope. Now, these many doctors are going to represent many joints, which is just polyarticular disease. So in the context of joint pain, you can really tell if there's one joint involved or more than one. If there's one joint involved, that's because of tuberculous arthritis, septic arthritis, or just gouty arthritis. However, if there are more than one joint involved, that is because of rheumatoid arthritis or just connective tissue disorders or rheumatic fever. Also, sometimes you can get more than one joints involved in seronegative arthritis. And just like that, you'll see that the one doctor on the left-hand side is just close to the starting line. I mean, he's proximal. While on the right-hand side, you're going to see the bunch of doctors and they're far away from the starting line. I mean, they're distal. So if the proximal interphalangeal joint is involved, that is because of rheumatoid arthritis or just connective tissue disorder. However, if the distal interphalangeal joints are involved, that is in psoriatic arthritis. The same way, you can also ask about involvement of spine, hips, knees, and these are seen in osteoarthritis or just tuberculous arthritis. If the sacroiliac joints are involved, that's because of ankylosing spondylitis or seronegative arthritis. And just like that, if there's first metatarsopharyngeal joint involved, that is seen in gouty arthritis. Now let's start. 3, 2, wait, what? There is someone who is having some issue. And that's a tiny doctor. You see that tiny doctor? And he is just pointing towards the big doctor? Well, that's because of the pattern of joint involvement. If the small joints are involved, that is seen in rheumatoid arthritis or just collagen diseases. Sometimes it's also seen in seronegative arthritis. However, if the large joints are involved, that is seen in osteoarthritis, rheumatic fever, or just septic arthritis. And besides that, large joints are also seen in tuberculous arthritis. Now, when you have this big doctor on your side, I don't think it's cheating. I think it's a totally fair play. Anyway, let's draw a cave. Cave? What? Is that really a cave? Wait, no. I think it's an operation theater, also known as OT. And I really don't understand who made this OT. I mean, just look at the design. That's totally unique. Now, what we see here. We see a doctor or a surgeon that is coming out of the OT with a patient. Now, that the fun fact about the operation was there was a male doctor alone with a female patient in the operation theater, and that was a secret operation no one knew about. Anyway, and how do I know about that? Well, good question. That's because rest of the whole staff is just sitting outside that operation theater. So if we keep jokes aside and we see that doctor, he's just migrating that patient out of OT1 to OT2. So this is going to represent the character of joint involvement that is migratory. If there is migratory involvement of joint, that's seen in rheumatic fever. And if you see those two surgeons sitting outside the OT in the green suit, well, they look quite symmetrical to me. So that's the symmetrical joint involvement, which is seen in rheumatoid arthritis, connective tissue disorders, and ankylosing spondylitis. Next to these two symmetrical sitting doctors is a boy in the blue, and the girl in the green. Now, that's a kind of asymmetry. You know, boy and girl, blue and green, that's asymmetrical. So, this Dr. Boy and the Dr. Girl are there to remind you of asymmetrical joint involvement, and this is seen in osteoarthritis, rheumatic fever, gonococcal arthritis, and enteropathic arthritis. One more thing about this young doctor in the blue is that he's madly in love with the girl, while on the other hand, the girl has absolutely no interest in him at all. So, this young flirty boy, disrespecting the personal boundaries of the girl, forcefully touches her and makes a contact. And ooh, hearts everywhere. Now, these hearts are there to remind you of contact, but not just contact, it's the sexual contact. So, when you see a patient with a joint pain, must ask about the sexual contact because that's seen in gonococcal arthritis or just Retter's syndrome, which is just can't see, can't pee, and can't climb a tree. Next up, soon after touching that girl, this boy got discharged. I guess that was too quick. Disappointed but not surprised. You really need to work on that, boy. So that discharge, soon after touching that girl, is going to tell you about urethral discharge, and that is seen in gonococcal arthritis and again in Ritter's disease. Next, we'd like to talk about the diurnal variation of the symptoms. And for that, we're going to draw a big moon and a big sun. Now, if the patient said that their joint pain is worse in the morning, which is just morning stiffness, so it means rheumatoid arthritis, collagen diseases, or just Bassett's disease, which is simply orogenital ulcers. On the other hand, if the patient says that their pain gets worse in the evening, that's seen in osteoarthritis, or if the pain gets worse at night, that is seen in tuberculous arthritis and gouty arthritis. Now, what next? We draw a man who is just sun moon bathing. Well, that man is there to tell you about photosensitivity. So, in a nutshell, if you see a patient with a joint pain, must ask about photosensitivity. That's because it's seen in various autoimmune diseases. And besides that man, what we got? Oh, a lady. And this lady is also taking sun moon bath. One more thing you'll realize is that her sun moon bathing didn't go just well. It just gave her rash. And guess what? This rash is just like nodules. So it's a nodular rash. So if you see a nodular rash and that is particularly painful on the shins, that's just erythema nodosum. And it's seen in rheumatic fever, and sometimes it's also seen in enteropathic arthritis and Bassett's syndrome. Now we draw a grave, and where there's a grave, there's a pangolin. And you can see right through that grave comes out a hand. And this hand is there to remind you of changes in the nails. So must keep Raynaud's phenomena or scleroderma in the back of your mind while you're taking history about the joint pains. And what about this pangolin? This pangolin is there to tell you about the scaly diseases. For example, psoriasis. If you encounter joint pain along with scaling eruptions on the extensor surfaces of the limbs, that's psoriatic arthritis. And what else we got? Oh, these are so beautiful butterflies. And these butterflies are pink in color along with the rash. And these rashy butterflies are there to tell you about the characteristic butterfly rash seen on the face in a patient with SLE. So if there's a patient with a joint pain, must try to see the butterfly rash on their cheeks. So until now, we have covered different dermatological associations with the joint pains. For example, the changing in nails, the scaly diseases, the butterfly rash on the face, the painful nodular lesions, specifically on the shin, and photosensitivity. That's enough of dermatological rheumatology, or whatever is it. Now, can we just take a little break from the associated symptoms and just talk about the progression of the disease? Well, to understand that progression, we draw these street lights. Now, as you can see, the first light is working, while the second light is not, and the third light is working again. So this is going to remind you of on and off attacks which are lasting for few days with the interval of freedom that is lasting for weeks. And this is seen in gouty arthritis. In simple words, if you see on and off attacks, keep gouty arthritis in the back of your mind. And one more thing, if they are just on and off episodes without deformities, that is seen in rheumatic fever, SLE, and enteropathic arthritis. Next, you'll see the second street light is deformed. So if there are remissions and exacerbation that ultimately lead to joint deformities, That's seen in rheumatoid arthritis and psoriatic arthritis. And after that deformed street light, you're going to see all of the street lights are working and they're just progressing so nicely till the end of the road. Now that means if there's a slow progressive course without remissions, that is seen in osteoarthritis and ankylosing spondylitis. Besides that all, if there's just one episode and you successfully treat it, that's septic arthritis or just tuberculous arthritis. Now, what else can we draw? We can draw a floppy heart balloon. And this floppy heart balloon is there to tell you about the heart failure. So if there's arthritis that is followed by the symptoms of heart failure, for example, fluid overload, this is because of rheumatic heart. So just keep it in the back of your mind. Now what? There's a circus show nearby? Let's go watch it. And whoa! To add some more spice, they added fire in the whole circus. Now, this fire is going to tell you about fever. So, if there's a joint pain in conjunction with fever, you're going to look for the rheumatoid arthritis, collagen diseases, rheumatic fever, or just septic arthritis. And now, just outside that circus, you see this man calling everyone for their attention through a megaphone. Oh, yes, that's a megaphone. So, this megaphone is going to tell you about the crackling sounds. Just like that. So, what does that mean? So that means if there's a patient complaining of cracking sounds in the joints while they walk, that is seen in osteoarthritis. So to reinforce this crackling sounds with the joint pains, we have given this person an elastic bandage on the knees to tell you about the joint pains and the crackling sounds. Now it's time to really dive into the circus and look what we found. A stool, a red stool, or a bloody stool. Yes, this red stool is going to tell you about bloody diarrhea. So if there's bloody diarrhea along with joint pains, that is seen in reactive arthritis or just enteropathic arthritis. And what's next? Over that stool is an acrobat who is just performing his act. And to make things more difficult, we just give him an eye mask or simply dry eyes. So must ask about the dryness of eyes if you see a patient with a joint pain. And just to add more spice to the circus, we add another acrobat. And as you can see, this is a girl, but without hair. She actually had the hair loss. So must ask about the hair loss in the patient with joint pain. Also, you're going to see that she's arching her back. Well, that's there to remind you of the back pain. And just like the boy acrobat, to make things difficult for her as well, we're going to give her a mask. And now I think she is just a ninja. She is just covering her face. She's bald and she has some extra elasticity in the back. Now, these features are going to tell you about dryness in mouth, hair loss, and arching of the back or just back pain. Now, that's all really about rheumatology section. What do you say? Shall we revise these all symptoms again in a minute? Okay, so if you see a patient with a joint pain, don't forget asking about dry eyes, rash, photosensitivity, hair loss, dry mouth, Raynaud's phenomena, psoriasis, back pain, arthralgia, arthritis, myalgias. And if you talk about this joint pain, you must ask about the number of joints involved. Then you're going to ask about the affected joints, proximal, distal, girdles, whatever they are. Ask about the pattern of involvement. Ask about the character of involvement, diurnal variations, and of course, ask about the associated symptoms. For example, crackling sounds, fever, rash, bloody diarrhea, urethral discharge, redness of eyes, cramps, or just you can ask about the sexual history. That you're going to ask about the progression, if they're on and off attacks, or there are deformities or the features of heart failure, or it's slowly progressive, or if there's just only one episode. Well, all that depends upon the presenting complaint of patient. That's all about rheumatology section. And finally, we can head over to our endocrinology section. Now, what's the mnemonic for this system? That is DART. D-A-R-T. Diabetes, adrenals, reproduction, and thyroid. And this section is going to be very short and quick, I promise. And why is that so? Glad you asked. That's because you have already covered all of these symptoms in the rest of the sketch. We're just going to give it a revision here. So sit tight as we're going to finish this as soon as possible. So just to reinforce the idea of DART, we draw a target sign and a dot here. Next up, for diabetes, we're going to draw a sugar daddy with a jar of candies that is really going to tell you about diabetes. Now we're not going to discuss the symptoms of diabetes as we have already gone through the whole sketch, but just as a refresher, I would like to tell you that You have to ask about the constitution symptoms. For example, there's increased diet, which is known as polyphagia, and it comes with the polydipsia and polyuria. Then you're going to ask about the microvascular complications. For example, changes in vision, blurring of the vision, lights, floaters, and that's all because of the cataract. Then you can always ask about the features of chronic kidney disease, for example, pallor, breathlessness, itching, and all these stuff. That's because of the diabetic nephropathy. Then you're also going to ask about the neuropathy symptoms, for example, tingling, numbness, burning in hands and feet. Also, you're going to ask about the autonomic nephropathy, for example, diabetic diarrhea or urinary incontinency, and so and so. So these were the actually microvascular complications known as retinopathy, nephropathy, and neuropathy. Then you're going to ask about the past history of macrovascular diseases, for example, CVA, which is a stroke. Also, you're going to take a past history of MI and peripheral arterial disease. Now, the patient can also present in DKA and honk. So be sure to rule out diabetes. Next up, this sugar daddy is madly in love with someone. So we draw your hearts, and these hearts are going to tell you about reproduction. Oh, the daddy likes to reproduce. Oh. So if there's a problem with libido or impotency, you can always go to our genitourinary section for more detail. Next up, we're going to give this daddy a thyroid bow. Now, this thyroid bow is dual representation of hypothyroidism as well as hypothyroidism. And just as a refresher for thyroid, you can always ask about nervousness, irritability, insomnia, palpitation, shortness of breath, tachy, chest pain, ankle edema, appetite, change in weight, constipation or diarrhea, weakness or lethargy, sweating, intolerance to heat and cold. The same way you can ask about amenorrhea, skin complexion changes, change in voice, dysphagia, dyspnea, blood in saliva, which are the features of actually malignancy. You're going to differentiate thyroid from the thyroid cancer as well. And finally, you're going to ask about pain in eyes or diplopia. And then you're going to see the neck and see that swelling. I think it's enough for thyroid. And what else? This sugar daddy is wearing a brand new shirt from the Addison's. So you're going to ask about the Addison's disease, which we have already discussed a lot in detail in the constitutional symptoms and GI symptoms modules. So head over to there. And that's all about the diagnostic art to history taking. Now, before I go, I would like to share a template for taking history with you guys. Now, first of all, you're going to take the biodata. For example, a young male patient named XYZ, son of ABC of age ABC, was admitted to hospital on the date via emergency. He's resident of XYZ and ABC by profession. Now in these two sentences, you're going to cover whole of the biodata of the patient. Next up, you're going to ask about the presenting complaint, why the patient came to the hospital. And these complaints are written in chronological order, which means the first complaint of the patient comes first in the list, and the recent complaint of the patient comes at the bottom. For example, the patient was presented with the following complaints: fever for 7 days and chest pain for 2 days. Now you're really going to take the past history right from the start, because this is going to help rule in or rule out most of the differentials. For example, my patient is a known case of diabetes, hypertensive, he is non-alcoholic. However, there is no significant history for drug addiction, hospital visit, previous accident, travel, etc. etc. That you're going to take history of presenting illness in great detail, and this is actually our lecture. Just remember one thing: you don't need to ask all the questions to every patient. Just tailor them according to your need. And finally, you're going to take some other histories. For example, if it's a woman, you're going to take menstrual history. You're also going to take past surgical history, family history, personal history, occupational history, socioeconomic history, and then finally, you're going to ask the current medicine.